each one of you, myself, Dr. Vaibhav Jain, and today we are going to learn about the psychiatry. So it is going to be a very crisp and concise class where I will be covering all the important questions that would be coming in your examination. Okay, your exam is approaching really soon, and we have got a very little amount of time, but yes, with the time we are having in hand, we can do wonders, and if we have the right approach, we are definitely going to pass, right? So with this particular thing, we are starting it off with the quote of the day. The quote of the day is that do not pray for an easy life, pray for strength to endure a difficult one. Right? You guys are doing your hard work, you are working, you are doing in the hospitals, and you are preparing for your PG examination. Definitely everything will fall into its place. You just have to have some patience and some hard work. A little bit of extra efforts is going to pay you up. Right? With this particular things in mind, let's begin with the session. The session first question we are having in front of us is going to be you have to be interactive. You just try to answer my questions what I want to ask, right? You will please try to answer. So we are having the question number 1 in front of us, and it will say a 25-year-old female patient is going to be coming to the hospital. So how to solve the question, that is important. A 25-year-old female patient is brought to the hospital. Her mother is stating that she does not feel good. She does not feel good. She likes to stay alone, and she don't talk with the people. She don't talk with the people. Earlier, she used to be very social. And when asked with the patient, she stated that she does not feel the pleasure. She does not feel the pleasure in those activities now. Okay, so what are the symptoms that you can conclude over here? What are the symptoms we are having over here? What are the symptoms you can expect here? Right? What are the symptoms? First symptom, she don't talk with anyone. She don't talk with anyone. She does not feel good. She does not talk with anyone. Does not talk with anyone is considered as alogia. Okay, this is considered as alogia. This is known as alogia. Okay, she does not talk with anyone. She does not goes out. She's not, she was earlier very social. Now she is not social, so she is having asociality. What kind of symptoms are the asociality? She is enjoying something earlier, and right now she does not feel good about it, right? This particular thing is known as anhedonia. So what is this anhedonia? What is this alogia? What is this asociality? All these things are what kind of symptoms? All of them are going to be negative symptoms. And they are the negative symptoms. In schizophrenia, in depression, we are having in psychiatry, two types of symptoms will be there. One is going to be your negative symptoms, another one is going to be your positive symptoms. So what are negative symptoms? Are these symptoms which are in front of us? They are known as negative symptoms. They are known as negative symptoms. They are known as negative symptoms, right? So we are having alogia, asociality, apathy. They don't want to go out. They just want to leave alone. All these things are what kind of symptoms? They are your negative symptoms. Negative symptoms, right? So what is going to be your answer in this particular case? What do you think? Why this thing is happening? You know one thing, this negative symptoms can be due to increase in dopamine or decrease in dopamine. These negative symptoms can be due to increase in dopamine or decrease in dopamine. Yes. So let's try to understand what are the different things we are having. Try to be interactive. If you are making mistakes, we are going to correct it here itself, right? So if you are making any mistakes, we are going to correct it here itself, right? So we are having this particular thing. We are having this particular track. These particular tracks we are having for the dopamine. Okay, you study about dopamine at various places. What are the places that you know about dopamine? You study about dopamine at various places. Sometimes this dopamine is increasing, you will be having happiness. Sometimes this dopamine is decreasing, you will be having sadness. Sometimes this dopamine is increasing, you will be having decrease in the prolactin. Sometimes this dopamine is concerned with Parkinson, right? So this is the same dopamine which is we are studying, and it will be showing certain different actions, right? So let's try to understand what is this dopamine and how it is going to exert different actions. So beginning with the first thing, we are having certain pathways. Okay, for this particular dopamine we are having certain pathways. What are the pathway we are having? The first pathway we are having is going to be mesocortical pathway. Four pathways we have to study. First one is mesocortical, second one is going to be mesolimbic pathway. Third one we are having is tuberoinfundibular pathway, and lastly we are having is nigrostriatal pathway. Okay, this is going to be your brain, this is going to be your brain, this is your corpus callosum. Here somewhere you will be having this particular part is considered as, this particular part will be hypothalamus. If you try to understand, this is going to be the hypothalamus, and below this will be what, this is going to be the pituitary. Here you will be having anterior posterior pituitary, this is going to be your optic chiasma, this is going to be your pons, and here you will be having medulla, right? And here you should be having what, somewhere here you should be having the cerebellum, right? This is going to be the complete story, right? Now we are having different pathways will be there: mesocortical, mesolimbic, tuberoinfundibular, and nigrostriatal pathway. So what is this mesocortical pathway? Who's NMC. So you can remember the mnemonic NMC. NMC is, that means mesocortical pathway is concerned with what kind of symptoms? Mesocortical pathway is concerned with the negative symptoms. Negative symptoms. What are the negative symptoms? We are having apathy, we are having alogia, we are having we are having anhedonia, right? So these are all what, negative symptoms. These are all what, negative symptoms. As sociality, they don't want to talk with anyone, they don't want to go out, they don't want to speak to anyone, they just want to live alone. These are going to be your negative symptoms. And remember why negative symptoms are there: because of decrease in dopamine. Because of decrease in dopamine in which pathway? Decrease in dopamine in mesocortical pathway. So whenever you will be having decrease in dopamine in mesocortical pathway, you will be having with symptoms, these are going to be negative symptoms. So you can simply remember negative symptoms are concerned with mesocortical pathway. Whereas what about this positive symptom? Positive symptom is concerned with mesolimbic pathway. So when you have increase in the dopamine, in mesolimbic pathway, what are the symptoms you will be having? You will be having positive symptoms. What are these positive symptoms? In psychiatry, what is a positive symptom, right? There are two important positive symptoms that you have to remember. One is going to be illusion, another one is going to be hallucination. Can anyone tell me the difference? What is illusion, what is hallucination? There are going to be two things. One is going to be illusion, another one is going to be hallucination. So what is going to be the difference between illusion and what is going to be the difference between hallucination? Okay, so what is illusion, what is hallucination? Can you appreciate this particular fact? All right. Illusion means what? Illusion means false perception. Illusion means false perception of a real object. For example, this is a pencil, right? If I'm perceiving this pencil as a sword, I will think like that this is a knife, or this is a sword, or this is a gun. This is what? This is known as illusion. This is known as illusion. So false perception of a real object is known as illusion. Whereas what is hallucination? Hallucination means now I don't have anything in my hand, but I can see it, right? If I can see it as a sword, as a knife, or as a gun, what is that? This is known as hallucination. So false perception, both of them are what? Perception. Perception means what you are perceiving, what you are feeling about it, right? So what I can see, if there is nothing and I can see, this is going to be hallucination. Whereas now this is known as illusion. Now this is known as illusion. So we are having two things: what is illusion, what is hallucination, right? Next pathway we are having is going to be nigrostriatal pathway. And whenever in this particular nigrostriatal pathway, you will be having decrease in the dopamine. When you have decrease in the dopamine in nigrostriatal pathway, you will be having a disease that is known as Parkinsonism. His disease, what you are going to call this particular disease, this is known as Parkinsonism, where it is characterized by bradykinesia. You will be having slowness of the movement, bradykinesia, tremors will be there. Patient will be having tremors, patient will be having rigidity, right? These are the characteristic feature of this Parkinsonism. He will be taking those baby steps. He will be having bradykinesia, everything will be slow. He will be having tremors, right? And he will be having rigidity will be there. And what is going to be the drug of choice? Would you like to tell me for Parkinsonism? The drug of choice will be, we can give levodopa is the most effective drug. Most effective drug is going to be levodopa or carbidopa. Levodopa plus carbidopa is the most effective drug. Carbidopa whereas the drug of choice will be ropinirole or pramipexole. Ropinirole or pramipexole. These are going to be the drug of choice. These are going to be the DOC. Right, so these are going to be the drug of choices in this particular case. Right, last pathway we are having is tuberoinfundibular pathway. This tuberoinfundibular pathway, what is going to happen when we talk about tuberoinfundibular pathway? We talk about another hormone. This is going to be prolactin. Dopamine is also known as what is another name of dopamine? It is also known as prolactin inhibiting hormone. And what is the function of prolactin? You can simply remember pro. Okay, so it is going to remember, you can remember, it is going to do the production of milk. It is going to do the production of milk. Prolactin is going to do the production of milk, and since there will be production of milk, do you think what happens in prolactinoma also? We can summarize here. Prolactinoma means there will be increase in the prolactin. Increase in the prolactin means increase in milk production, and till the time mother is producing the milk, do you think she is going to get pregnant? Right, she is not going to get pregnant. She will be having amenorrhea, right? So she will not have the periods, and she will be having amenorrhea will be there. So in what happens in prolactinoma, you will be having excessive production of milk. Excessive production of milk will be considered as what we can call it galactorrhea. So she will be having galactorrhea, she will be having amenorrhea, and I'm talking about prolactinoma. Let's say I'm talking about a tumor of prolactin. This is going to be prolactinoma, and this prolactinoma cells will be here. So when you have increase in the cells, what is going to happen? The cells are going to touch what? It is going to touch the optic chiasma also, and when it is going to touch the optic chiasma, you will be having a specific vision. This is known as bitemporal hemianopia. This is going to be bitemporal hemianopia. So this is going to be the thing in the prolactinoma also. We can correlate here prolactin, and the hormone that is going to be working here, which is going to be prolactin inhibitory hormone. This is known as dopamine. In which pathway? Sir, in tuberoinfundibular pathway. Okay beta, so what is going to be the drug of choice here? So whenever you are going to have prolactinoma, what I can do? I can give a hormone. What is the hormone I can give? I can give dopamine to the patient, and this dopamine is also known as prolactin inhibiting hormone. Now patient is having prolactinoma, so I can give what? I can give dopamine agonist, and the only two drugs we have to remember, that is going to be, first one is going to be bromocriptine, and second one is going to be cabergoline. These are the two drugs we can give. These are going to do what? These are going to decrease the prolactin in the tuberoinfundibular pathway, and you will be having resolving of the symptoms, right? So we are having different pathways. I've told you 4 pathways for what? I've told you 4 pathways. What are those 4 pathways? I've told you we are having 4 pathways of dopamine. First pathway is going to be mesocortical. Remember mesocortical, what was the mnemonic? NMC. So mesocortical is concerned with the negative symptom. Second one I have told you is mesolimbic. It is concerned with positive symptoms. Here you will be having positive symptoms, like you are having illusion, like you are having delusion, not delusion, like you are having illusion and hallucination. So whenever you are having increase in dopamine, you will be having these symptoms. You can do what? You can decrease dopamine, right? Here what is happening? This negative symptoms are happening. So what you can do? Negative symptoms are happening because of decrease in the dopamine in mesocortical pathway. So what you can do to treat this situation? You can increase the dopamine in mesocortical pathway, and this is what happens in the depression. So you increase the dopamine, you increase the serotonin. What will happen? The patient will be okay, patient will be fine. Third pathway I told you is going to be nigrostriatal pathway, which is totally connected with the Parkinsonism thing, and this Parkinsonism is happening because of decrease in dopamine. So all the drugs are going to do what? They are going to be levodopa, carbidopa, ropinirole, pramipexole. All of them are going to do what? They are going to increase the dopamine in nigrostriatal pathway. You will be having improvement in the symptoms here, right? And last pathway we are having is tuberoinfundibular pathway, where you will be having, whenever you are having decrease in dopamine, you will be having increase in prolactin, and you will be having prolactinoma symptoms. If you want to treat this prolactinoma, you can give dopamine to the patient. 2 drugs only which are going to be dopamine agonists that you have to remember. One is going to be bromocriptine, second one is going to be cabergoline, right? Is that okay with you, right? So what is going to be your answer in this particular case? She is having what kind of symptoms? She is having negative symptoms, and negative symptoms are suggestive of what? They can be suggestive of depression. They can be suggestive of depression. So what is going to be your treatment? Now try to answer. Okay, what do you want to do? Do you want to decrease dopamine in mesolimbic? First of all, let's talk about the limbic. This mesolimbic is concerned with what? It is concerned with negative symptom or positive symptom. Remember, NMC, negative is mesocortical. So this one is concerned with positive symptoms. So sir, this cannot be the answer. Second one, increased dopamine in mesolimbic tract. This is also cannot be the answer, right? Because it is also talking about mesolimbic. So two options are already ruled out. Third option we are having is going to be increase dopamine in mesocortical pathway. So if you will increase dopamine here, what you will be having? What you will be having? You will be having treatment of the symptom, right? But what the examiner is asking is very, very important. These symptoms are due to what? He is asking these symptoms are due to what? So these symptoms, these are the negative symptoms. And why you are having negative symptoms? Due to decrease in dopamine in mesocortical pathway. Decrease in dopamine in mesocortical pathway is going to produce which symptoms? This is your mesocortical pathway. If you have decrease in dopamine in mesocortical pathway, you will be having negative symptoms like apathy, alogia, anhedonia. Okay, so this is going to be the answer in this particular case. The answer is going to be what? Answer is going to be D. You understand the story of dopamine? Okay, give me a confirmation whether you understand this or not. Yes. So this is going to be the story of dopamine. This is going to be the story of dopamine, right? Just a moment. Okay, so this is going to be the story of dopamine that we are having over here, right? Better. Now coming to the question number two we are having is going to be a 29-year female arrived at the emergency. A 29-year-old female is arriving at the emergency and in the emergency department with the police, and now when she is accusing that her all the neighbors, uske sare padosi, all the neighbors are conspiring against her and they want to harm her, and they want to kill her. Okay, after police investigation, the police has confirmed that that there is nothing like this. Police has given the confirmation it is nothing like that and it's a false accusation, right? But she have a firm and fixed belief. What kind of a disorder will explain this? What is this particular thing? So whenever you see a firm and fixed belief, whenever you see a firm and fixed belief which is unshakable, a firm and fixed belief which is unshakable, even if God will come and say she will not agree with this, right? She will always be like that. She will always be like okay, she will always think like that she is the right. Okay, so this is a firm and fixed belief. She is having a firm and fixed belief which is unshakable. This is going to be in the favor of what? This is going to be delusion. What is delusion? You know what is hallucination, you know what is illusion. Illusion is false perception of a real object is illusion. Okay, absence of any object, you are watching something. This is going to be what? This is going to be hallucination. This is going to be hallucination, right? But here in this particular case we are having what? Here we are having delusion. What is delusion? So delusion means you will be having a firm and fixed belief which is unshakable. Nobody can shake this, right? This is going to be known as delusion. This is going to be known as delusion, right? So this is going to be a type of delusional disorder. That is going to be the thing over here, right? What are the different kinds of delusion we are having? What are the different delusions we are having? Let's try to understand. We are having delusion of reference. We are having delusion of reference. That means they will always think like that. Okay, everyone is referring to him, everyone is referring to her. That means three people are talking about something and this particular person will think, okay, they are talking about me, right? So this is known as, they will always think like that, they are referring to him or her, right? So this is going to be the delusion of reference. They will always think like that, okay, two people are talking, they must be talking about me, like that. Okay, second delusion is going to be delusion of grandiosity. Delusion of Grandiosity. Grandiosity means what? Grandiosity means god-like delusion, right? So this person will think like that, I am the god, I am the most superior person on this particular planet. And this is going to be, remember, this is going to be a firm and fixed belief. This is going to be a firm and fixed belief. No one can shake this. Okay, even if you give hundred of proofs, he's not going to admit his fault, right? Next one is nihilistic delusion. Nihilistic delusion, that means delusion of negation. That means delusion of negation. This particular person will not feel, he will feel like that this arm is not his arm, right? He will have a very negative delusion. This is going to be nihilistic delusion. He will think like that everything is over, right? So this is going to be the nihilistic delusion we are having, right? What is this illusion and hallucination? Remember, illusion means false perception of a real object. False percep, these are the disorders of illusion, and hallucination are the disorders of perception. Perception is what you are perceiving, right? What you are feeling about it. So false perception of a real object, this is known as illusion. For example, there is a rope on the road and you are perceiving it as a snake. This is known as illusion. Whereas whole hallucination, false perception of a real false perception. Hallucination is also false perception, but in absence of anything, in absence of object. In absence of object, this is going to be known as hallucination. This is known as hallucination, right? What is superstition? Superstition means if I am having a delusion that I am the god. Okay, if I am having the delusion that I am the god, maybe I am having the delusion of grandiosity, and 4 or 10 people are supporting me on that, they will be like, no, he is the god, right? So if some people are supporting a delusional disorder, this is known as superstition. When superstition means what? Multiple people are supporting the same disorder. People are supporting the same thought, same disorder, right? When all of us are all people are believing, okay, he is right, he is telling the truth. This is known as superstition. Like earlier we used to have a superstition, you will kill some animal and then there will be rain will be coming. One person will think like that, this is known as delusion. Now lots of people are believing his delusion, this is going to be a superstition, right? You go somewhere, when lots of people are believing a same thing, this is known as superstition. Delusion means there will be a firm and fixed belief in a single person, this is going to be delusion. What is illusion? Illusion is going to be false perception of a real object. That means this pencil is looking like a sword to me, okay, this is going to be illusion. And now in the absence of any object, if I am finding this pencil, I am finding a pencil, this is going to be what? This is hallucination. This is known as hallucination, right? What are the important types of delusion we are having or hallucination? Remember, just remember one more important thing. This hallucination is going to be what? This hallucination is going to be as vivid as real. This hallucination is going to be as vivid as real. So it will be appearing completely real. Like for example, I can see this pencil. Now also I can see this pencil, everything that I can see, I can tell you the minute details, the color, the everything. If I am having visual hallucination, this is going to be exactly, I can tell you each and every minute detail. Okay, it should be happening in the outer space. It should be happening in the outer space. Even some people will spend the rest of their life with the hallucination. When they die, they will get to know, okay, they were hallucinating like from last 20 years. They are spending their lives with someone and with such kind of a person which are not even existing. Okay, so these are going to be the disorder. So this should be happening in the outer space or objective space. What is the most common type of hallucination? Most common type of hallucination is going to be auditory hallucination. Most common type of hallucination is auditory hallucination. Auditory hallucination. in if you have some kind of a organic mental disorder, if you have some kind of organic mental disorder, that means you are having some kind of trauma, some kind of injury. In this particular case, what is the most common type of hallucination you are going to have? This is going to be visual hallucination. This is going to be visual hallucination. This is going to be the visual hallucination. Okay, what is the most common type of if you want to ask about most common type of delusion? What is the most common type of delusion? Delusion means firm and fixed belief. Speak with me, you will remember what is delusion. Delusion is a fixed and firm belief which is unshakable. Fixed firm belief which is unshakable. This is going to be the most common type of delusion. What is the most common type of delusion? Delusion of persecution. Delusion of persecution. That means someone is trying to kill me. When these patients are going to come to you, they will be like, okay sir, my neighbor is conspiring against me, they want to kill me, or my friend is trying to kill me, they are doing something, they just want to harm me. These are going to be the words of this particular person. You think like that this person is having what? He is always worried. He is always worried that somebody is trying to kill him, right? This is the most common type of delusion that people are having. This is known as delusion of persecution. Delusion of persecution, right? So these terms are clear to you. What is hallucination, what is illusion, what is superstition, what is delusion? Okay, at least give me a quick confirmation whether these terms are clear to you, you are understanding this. So what is this delusion? Delusion is the fixed firm belief which is unshakable. What is illusion? False perception of a real object is illusion. Hallucination, false perception of a real object in the absence, false perception in the absence of any object, right? And superstitions are going to be, people are going to be supporting the delusion. People are supporting the delusion. This is going to be what? This is going to be your superstition. Superstition, right? Now comes the next question. Next question is, a 27-year-old boy brought to the OPD. Now a patient is brought to the OPD by his family with the complaints of hallucination. This patient is having what? Hallucination. From how much time? From the last 2 months. After a breakup, he is having this particular thing with his girlfriend, right? And the boy hear voices. इस लड़की को, this boy is going to hear voices talking about him. These voices are talking about him and commenting on his actions. These voices are commenting on his actions, like whatever he is doing, the voices are commenting on his actions, like he is writing, he's drinking water now, he's moving like that. Okay, so voices are commenting on his actions. The boy also stated that he feels like someone is inserting these thoughts into his mind. So these thoughts are inserted into his mind by someone else, right? With the help of some other technology, right? What is the probable diagnosis in this particular case? What do you think is going to be the diagnosis? So whenever you see in the question, whenever you see the things, voices, when you see the thing, voices is going to be referred to as third person. And whenever these voices are written, this means this patient is having some kind of a hallucination, and this is going to be, voices means auditory hallucination. Hallucination means what? Is it going to be any real object? No, there will be no real person, but he is getting those voices. And remember, I told you it should be happening in the outer objective space. That means he will be hearing those voices from outside, from external source, right? So these are going to be auditory hallucination. Apart from that, they are also having the running commentary. Running commentary means what? Stating his actions, like I'm writing down. Okay, these are what? Running commentary. And there he is also having this particular thing, that someone is inserting thoughts into his mind. This is known as thought insertion. This is known as thought insertion. This is known as thought insertion. So how a patient is going to present to you, these are going to be the symptoms. Okay, so a young boy is coming to you after the breakup with his girlfriend. He's hearing those voices into his ear, right? They are commenting on his actions, and he's having what? He's having running commentary, and he thinks like that someone is inserting all those thoughts through his some kind of a technology. This is going to be your thought insertion. So when you have all those symptoms, these are the symptoms. What you will suspect, sir, these are the symptoms of something psychosis like symptoms or schizophrenia like symptoms. So what are the option we are having? We are having schizophrenia. In exam we got options like schizo, we got schizophreniform disorder, we got options like brief psychotic disorder, acute psychotic disorder. Where should I classify this particular thing? let's try to understand how to make the classification of this particular thing, right? So this is what we are talking about. Who gave this particular term? The term psychiatry was coined by whom, or the term schizophrenia was coined by whom? Okay, so remember the scientist who coined this particular term, Christian Johann Riehl. Johann Riehl, he is considered as the scientist who discovered who coined the term psychiatry. Psychiatry was coined by Christian Johann Riehl, whereas who coined the term schizophrenia? The term schizophrenia was given by Eugene Bleuler. Eugene Bleuler, and Eugene Bleuler has given the term schizophrenia. Schizophrenia. Now he has given four symptoms. He has given four symptoms, and they are known as 4A of Bleuler. Okay, they are known as 4A's of Bleuler. Right? What are the 4A that you have to remember? One is going to be affective disturbance. Affect means what? Affect and mood are going to be two things. Mood is going to be what? What is the difference between mood and affect? Mood and affect are going to be the same thing, but mood is going to be a long-term thing. Long-term. You always say, sir, it's not in my mood. I'm not in a mood. This is going to be a long-term situation. Whereas affect is going to be the thing we are having on the cross-sectional point of time. Cross-sectional point of time. That means now what is happening? This is going to be what? Both of them are going to be emotion. Both of them are going to be emotion. So cross-sectional point, if I talk about, this is going to be what? This is going to be the affect. Whereas if I talk about long term, like since morning I don't have a mood, right? This is going to be the mood, right? So affective disturbance will be there. First thing, mood disturbance will be there. Affective disturbance will be there. Either it can be blunted, either it can be flattened, right? Like for example, patient is sitting, he's not happy, he's not sad, the emotions are blunted. Okay. Second thing, autistic thinking. What is the meaning of autistic thinking? That means this patient is having preoccupation with the self. That means he's only thinking about himself. Okay, and he does not have concern about the external reality, what people are doing, what other people are doing. He don't care about it. This is going to be known as autistic thinking. He's only thinking about himself. What he is doing, he's happy with that, right? Third thing is going to be associative looseness. Okay, so he's having associative looseness. That means he's not going to have connection between two topics, right? He is talking about something and then he will jump suddenly to another topic. This is going to be associative looseness, and ambivalence will be there. This is going to be simultaneously opposing the feelings. Like he will be happy, he'll be like I am happy, and within sometimes he will become what? Sad. So these are the 4A of Bleuler. Okay, these are the 4A's of Bleuler, right? These are the 4A, but we are not checking that. We are checking the 11 symptoms, and these are known as 11 SFRS symptoms. These are Schneiderian first rank symptoms. These are going to be 11 SFRS symptoms. On the basis of what we are going to be identifying, these are going to be Schneiderian first rank symptoms, on the basis of which we are going to identify whether the patient is having schizophrenia or other things, right? So we can have first rank symptoms. These are going to be audible thoughts. We can have first voices. First will be voices, so we can have audible thoughts. That means this patient will be having thoughts will be coming aloud. Second, we are having voices arguing. That means two voices are talking about him. Okay, he's doing something and two voices are talking about him. Voices are releasing the thoughts, right? Third thing, you can have voice commenting on the action. This is going to be running commentary that just now we have seen. So we can have three voices symptoms, and these are going to be the auditory hallucination part. These are going to be the part of auditory hallucination. So if someone is having auditory hallucination, second thing is going to be this particular thing is what? Somatic passivity. Somatic passivity means somatic means body. So somebody else is controlling his body. Somebody else is controlling the body. So if a patient is thinking like that, someone else is controlling my body, this is known as what? This is known as somatic passivity. Somatic passivity. Third symptoms are going to be the thought symptoms. These are going to be thought insertion, thought withdrawal, and thought broadcast. Someone is trying to steal my thoughts. This is thought withdrawal. We can have thought insertion, that someone is trying to put thoughts into my mind, and someone is whatever I'm thinking, it is broadcasting, that whatever I'm thinking is getting very loud and people are able to hear this. These are going to be the thoughts. These are going to be the thought symptoms. These are going to be the thought symptoms. So we can have thought insertion, thought withdrawal, or thought broadcast will be there. What are the made effect, what are the made violation, and made impulse? Made effect means someone else is controlling the mood, right? So it is like an external force is controlling him. Made means what? External force is controlling. Made means what? External forces controlling. This is known as made effect. We can have made affect. Affect, you already know what is affect. Affect is going to be the emotions on a cross-sectional point of time. So he will think like that someone else is controlling his mood. Made impulse, like he's trying to put his hand into the fan, right? And he will be like, okay, I'm not doing this, someone else is trying to put my hand into the fan. This is known as made impulse. Made violation, he is going to do certain kind of action, and that is also he will be referring that someone else from the external site is going to do all those things. This is going to be the made symptoms, right? Three made symptoms are there. Three voices symptoms are there. These are going to be auditory hallucination, we can have somatic passivity, we can have thoughts symptoms, we can have made symptoms, and we can have delusional perception. Delusional perception means what? He will be having firm and fixed belief, which is unshakable, you cannot shake this particular belief, right? These are what? These are Schneiderian first rank symptoms. Schneiderian has given how many symptoms? 11 first rank symptoms he has given, right? So we are having what things? We are having these type of things. We are having what? Who coined the term psychiatry? Wherever you are, just try to speak. Who coined the term psychiatry? The term psychiatry was given by Sir Christian Johann Riehl. Christian Johann Riehl has given the term psychiatry. Who has given the 4A's? 4A's was given by the Bleuler. Who has given the term schizophrenia? This is your Eugene Bleuler. And we are having 11 SFRS symptoms. These are going to be the symptoms. What are the symptoms? Voices. Three voices, that is going to cause audible thoughts aloud. Okay, voices arguing about him, voices giving commentary. Okay, second one we are having is going to be somatic passivity, that someone else is controlling the body. Next is going to be about the thought withdrawal, thought insertion, and thought broadcast. Made effect, made impulse, and made violation, and delusional perception. This is going to be the firm and fixed belief, which is going to be unshakable. So these are going to be the symptoms. So what are the symptoms you can appreciate over here? In this particular case, you are having auditory hallucination, yes or no? This patient is having voices coming. This patient is hearing the running commentary, yes sir. Thought insertion is also there, sir. Okay, voices are also there, auditory hallucination is also there. So this can be features of schizophrenia. These are the features of schizophrenia. And in this schizophrenia, what you need to remember, if these symptoms are persisting for more than 6 months, then you make the diagnosis of schizo, right? If these symptoms are persisting for more than 6 months, then you make the diagnosis of schizophrenia. Otherwise you will make, if these symptoms are going to be for 1 to 6 months, if these symptoms are going to be for 1 to 6 months, we call it what? We call it schizophreniform disorder. And if these symptoms are persisting less than 1 month, okay, less than 1 month, if these symptoms are persisting, we call them acute psychotic disorder. We call them brief psychotic disorder, brief or acute psychotic disorder. So in this particular case, it is already given, it is not less than 1 month, because already given the timeline. The timeline is what? Timeline is from the last 2 months is facing all this kind of symptoms. So this is going to be what? This is going to be schizophreniform disorder. So answer in this particular case is going to become what? B, that is going to be schizophreniform disorder. You understand how to make the diagnosis and what are the different things. They will be giving you these confusing terms like schizophrenia will be more than 6 months. Okay, schizophreniform 1 to 6 months. Brief or acute disorder, psychotic disorder is going to be less than 1 month. This is going to be the less than 1 month, and the term psychiatry and all those things we have discussed, right? So next question we are having is in the front of you is going to be a 28-year-old male patient is presented to the OPD. The clinician has asked the patient question, where do you work? What was the question the clinician is asking? He is asking, where do you work? The patient replied, India is a beautiful country. India is a beautiful country. Modi ji is the prime minister. Mr. Modi is the prime minister. I have a beautiful girlfriend and we work together. Okay, but did not tell the answer to the question. What was the question they have asked? They have asked about the where do you work. He came near the work, we work together, but he did not answer where he is going to work, right? So he did not answer what kind of formal disorder this patient is having. Try to answer what is the formal disorder this patient can be having. Does he have the loosening of association? Does he have the circumstantiality? Does he have the tangentiality or incoherence? What is going to be the disorder over here? What do you think is the disorder over here? What is the disorder over here? So let's try to understand what are the thought disorder we are having. What are the thought disorder we are having? So thought disorders are very important. We can have certain thought disorders. Okay, so first thought disorder we are having is about the flow of thought. Flow of thought. Flow of thought means what? The stream of thought. Flow of thought, it is also known as stream of thought or speed of thought. Stream of thought. We can have increased in the stream of thought, like I'm talking very fastly, and you're not able to understand. This is going to be what? This is going to be increase in the flow of thought, right? Increase in the speed. Some people are speaking in very much speed. This is going to be what? This is going to be leading to increase in speed. This is going to be what? This is going to cause flight of ideas. Increase in speed, and that would lead to flight of ideas. That means he's not able to tell the complete story, and he's going to speak too much fast that he's already losing some words, right? So that is going to be a feature of mania. So when you see a patient of mania, you will be finding these patients are speaking too fast, very fast, right? You can have decrease in the speed of thought. You can have decrease in the speed of thought. This is also known as inhibition. Decrease in the speed of thought. Speed of thought. This is known as inhibition. This is known as inhibition. This is known as inhibition, right? Inhibition is a feature of what? When you have the decrease in the speed of thought, that means you are talking very slowly, right? This is going to be a feature you will be finding with the depression, right? So this is a feature you will be finding with the depression. These are the people who are going to speak very slowly. Many patients are going to speak very fast. So we are having two things. One is going to be this flow of thought. Which patients are going to be speaking fast? You will be having mania patient. Which are going to be slow? These are going to be depression patient, right? Second thing is about the content. This is going to be about the flow of thought. Second thing is about the content of thought. What is the content of thought, right? This content of thought is very important, because content of thought will be having what? Delusion. Delusion is a disorder of content of thought. This is the question they are asking again and again. So what is the content of thought here? What is the disorder of content of thought? This is a previous year NEET PG question. So this is going to be the content of thought will be having delusion. And what is the most common type of delusion? Most common type of delusion is going to be, definitely we have discussed, it is going to be delusion of persecution. Delusion of persecution. That means someone is conspiring against me, someone is trying to kill me, someone is trying to harm me. This is going to be delusion of persecution. This can be a feature of schizophrenia. This can be a feature of schizophrenia. Okay, then comes the form of thought. How the thought is formed. Then comes the form of thought, right? Then comes the form of thought. What is the form of thought? We can have first thing, this is going to be derailment. Rail is the train, right? Derailment means this particular person is going to have problem with the formation of thought. How he's going to present the thought, he will be like, he will be telling the first sentence like, okay, I'm going to join this particular job in a very big MNC company, and I want to go to the space. So what is going to be the thing, what is going to be the thing, he suddenly started talking about what, he was talking about his job, and suddenly he will talk about the space. He will talk about space is a very good thing, you should go to space, we are having all this and that. So this is going to be the derailment. That means there is going to be loose, there is going to be breakdown between a single thought. He will be talking like that, okay, I want to eat ice cream, my name is Dr. Vaibhav Jain, right? So there will be what, there will be derailment, there will be dissociation will be there, right? So the derailment is the formation of the thought, right, form of the thought. Second, like we are having loosening of association, loosening of association between the thoughts, loosening of association. This is also going to be example of formation of thought, right? We can also have incoherence. Incoherence, you can also call it word salad, right? So he will be telling you multiple things, word salad will be there, multiple words, and you are not going to get to derive the meaning of words, right? They will be telling you profile, untitled skin, untitled dogs profile, like that. He will be telling you multiple words, and you are not able to identify what he want to convey. This is known as incoherent. This is known as incoherent. He will be giving you word salad, which is going to have no meaning, which is going to have no meaning. So you will be having this word salad. Okay, then what is the another thought disorder form of thought? You can have tangentiality. Tangentiality. What is the meaning of tangentiality? In the mathematics we have studied about the tangents. What are the tangents? Tangents are going to pass from somewhere, but then they are not going to touch, they are not going to touch, right? So tangentiality means they are going to pass from somewhere. That means if you ask the question, that is what our question is, if you ask the patient where do you work, he will be telling you all the story around it, but he is never going to reach to the point. He is not never going to tell you what you want to know, right? He is going to tell you, you ask what is your name, he will tell you, okay, I live in that particular city, my father is doing that, my mother is doing that, I'm doing this kind of job, and this is my wife, my children, everything he will tell you, but he will not tell you what he is doing, right? So what you ask, you are never going to get. This is known as tangentiality. That is also a formal thought disorder. Formal thought disorder means formation of thought will be disturbed, right? You can also have one more entity. This is going to be neologism. What is neologism? Neologism means formation of a new word, coining a new term, coining a new term, coining a new term which has no meaning, okay? This is bakasha, like that. You don't know what is bakasha. There is no meaning of this particular word, and you have never heard about this word as well, right? So this is going to be known as neologism. Neo means new, logism means there will be new generation of a new word, right? So this is going to be a neologism. It is a feature of what? It is a feature of which disease? These are the people of schizophrenia. It is a very characteristic feature of schizophrenia. So schizophrenia people are going to make what? Neologism, right? So we are having flow of thought. Flow means you will be having the speed of thought. Flow of thought we have discussed. We have discussed about the content of thought. We have discussed about the formation of thought. Now we are going to discuss about the possession of thought. Four things we are having. Now we are going to discuss about the possession of thought. What is the possession of thought? We can have the same thing that we have discussed. We can have thought insertion. We can have thought insertion over here, that someone is trying to insert thought into my brain, someone is trying to put their thought into my brain. This is known as thought insertion. We can have thought withdrawal. Thought withdrawal means someone is trying to steal from my brain, right? So that is going to be thought withdrawal. We can also have thought broadcast. That means whatever I am thinking in my brain, I am thinking inside my brain, but these things are broadcasting, people are able to hear this, right? So all these are the thought disorder. Very important thing. People are asking NMC NBE people are asking question from here, right? You have to understand this. What are the thought disorders we are having? We are having thought disorders. These are going to be the flow of thought. Flow means the speed of thought. Content, what is the content of thought? It will be having delusion. Delusion, they have asked 2 to 3 times. Delusion is a disorder of content of thought, right? Next question is about the formation of thought. Next question is about the form of thought, and lastly we are having possession of thought. Lastly we are having possession of thought, right? So what is the question of we are having over here? So here in this particular question, you are asking your patient something, and he's answering, I have a beautiful girlfriend, prime minister is the Modi ji, right? Who is the India is a beautiful country, but he's not reaching that. Where does he work? So what is going to be your answer? Is it a loosening of association? No. Is it circumstantiality? Circumstantiality means what? He will start from a point A, he will go all the way around, but ultimately he will reach to the answer. Ultimately he will reach to the answer. This is known as This is known as circumstantiality. That means if he will be giving you answer, this is known as circumstantiality. He will tell you all these stories, and ultimately he will tell that where does he work. This is known as circumstantiality. Tangentiality, we have discussed tangentiality. That means he will pass near through this, right? He will go all the way up, he will come here, but he will pass away, right? He will never going to tell you the answer. This is going to be the tangent. This is going to be the tangentiality, right? And incoherence means what? Incoherence means, obviously you know, this is going to be word salad. So here we are having no word salad. This is going to be the C. Answer in this case is going to be C. Answer in this case is going to be C. Right? What is the next question in front of us? A 29-year-old girl has presented to OPD with the complaints of regular washing of hands. She is having complaints of regular washing of her hands, although she knows that it is completely illogical. This is illogical, yes, but still she is not able to control this type of behavior, right? When she tries to control this, when she tried to control it, she had a feeling of anxiety, and depressive mood will be there, right? All of the following are relevant to this disease except. So what is your diagnosis in this particular case? Your diagnosis will be what you are suspecting this patient is having. What? She is always washing her hand, right? If she is not going to wash her hand, she will be having the feeling of anxiety, she will be having depression, right? She does not feel good about it, right? So what is the disease we are having? What is the problem we are having over here? This particular thing we are having the problem. What is the problem? This is a case of obsessive compulsive disorder. This is a case of OCD. This is a case of OCD. And when you have the OCD will be having two components, beta. First one is going to be obsession. First one is going to be obsession, and second component is going to be compulsion. Second component is going to be compulsion. So what is the obsession over here? The obsession is here, this patient will be having constant repetitive thoughts in her mind. She is having a constant obsession means what? Constant repetitive thought. She will always have the thought, okay, your hands are having the germs, you should wash it. Okay, so this is a constant repetitive thought which is going to be in her mind. Thought will be there, constant repetitive thought will be there, right? This constant repetitive thought will be there, and this constant repetitive thought is going to cause what? It is going to cause anxiety in the patient. If she is not going to wash the hand, she will be having anxiety, she will be having palpitation, she will not feel good about it, right? She will be having depressive mood, she will be having feeling of anxiety. And what is compulsion? Compulsion is the motor act. Always remember, compulsion is the motor act. That means she is going to go to a washroom, she is going to wash her hand. This is going to be the compulsion. Compulsion is a motor act to overcome the anxiety, to overcome the anxiety and to overcome the obsession, basically, right? So this is going to be a combination of these two things, and this two things together are known as what? This is known as OCD. This is known as obsessive compulsive disorder, right? So you will be having an obsession followed by compulsion, you will be fine. You have the obsession to wash the hands, this is going to be followed by the, you have the obsession of constant repetitive thought that your hands are dirty, they are having the germs. This is obsession. What is compulsion? You wash your hand, you will be having what? Decrease in the anxiety symptoms. This is known as compulsion. So this is going to be the obsessive compulsive disorder. If you ask me what is the most common type of OCD we are having, this is the most common type of OCD we are having. OCD we are having is going to be obsession of the same. I'm telling you, obsession of contamination. Obsession of contamination. Contamination means something is present on the hand, right? Obsession of contamination followed by compulsion of washing, followed by compulsion of washing, hand washing. So this is the most common type of OCD we are having. Most common type of OCD we are having is obsession of contamination followed by compulsion of hand washing, right? So this is going to be what kind of a disease? Is it going to be ego dystonic or is it going to be ego syntonic? We are having two things. One is going to be ego syntonic, one is going to be ego dystonic. Ego syntonic means it is loved by the self, like we are having personality disorder. Some people are narcissistic, some people are histrionic personality, right? They will be happy with themselves. Everyone, you will tell that this person is toxic, but this person, if you ask, that particular person is very happy with himself. You will be like, when you judge another person, you judge on the basis of your personality, right? But this particular person is happy with himself, right? So this is known as the person who is happy with himself. That means this personality disorders are going to be ego syntonic. Syntonic means they are loved by the self. Dystonic means they are not loved by the self. So remember this particular problem. This particular problem is going to be what? OCD is going to be a ego dystonic disease. Yes, patient will not like it. Patient will be like, he will always think, okay, this is a wrong thing that I'm doing. Every time everyone understands this particular thing, that nobody should wash hands every time, right? Every time, like 5 to 10 times in an hour, he will be washing the hands. So this is a problematic thing and he knows about it, and he is the one who is going to the hospital, right? So this is going to be a ego dystonic thing. This is a true statement. Second, insight is present. Insight means what? Insight means awareness of disease. Insight means awareness of disease. Yes, this patient is having awareness of disease, yes or no? I told you we are having two group of disorder. One is going to be your neurotic disorder, one is going to be your psychotic group of disorder. One is going to be neurotic group of disorder, another one is going to be psychotic group of disorder. So what is this neurotic group of disorder? We are having anxiety, we are having OCD. Here the patient will be aware. Here the patient will be aware about the disease. That means insight is going to be present, right? But what about the psychotic disorder? Remember, in psychotic disorder, anxiety, this insight will be absent. Like people are having schizo. People are having schizo. They don't know whether they are having schizo, yes or no, right? So psychotic disorders like schizo, they might be having what? They might be having this particular thing. They might be having, patients are having schizophrenia, they might be having this loss of insight, right? They can be present, but generally this is lost in the psychotic disorder. What about the judgment power is normal, yes or no? This person is having normal judgment power. How you are going to assess the judgment power? I will ask you the simple question. I will ask the patient simple question. What will you do if you have the fire in the room? And the patient will be like, I will jump on the fire, I will kill the fire. Or maybe there is a tiger in the room and the patient will say, okay, I will kill the tiger. That means judgment is not intact, right? If judgment is going to be not intact, that is going to be loss of judgment, right? Here in this particular patient, he is having a disease, he is having an obsession. He is having an obsession, that is constant repetitive thought which is coming into his mind to wash the hands. If he will wash the hand, this compulsion is completed, he will be fine, right? So judgment power is going to be okay. Judgment power is normal. So this is also going to be a true statement. Okay, so insight is going to be present. This is also a true statement because this is a neurotic disorder. OCD is a neurotic disorder and insight will be present. So which one is left? Reality testing is absent. No sir, reality testing is going to be present. It is not going to be absent. This is going to be present here, and this patient will be knowing what is real, what is true, what is false. This patient will be knowing what is true, what is false. So this is going to be the wrong statement here, and this is going to be the answer, because they are going to ask you about the which one of the following is going to be relevant to disease except. Remember, these words are important. Except means which one is not going to be there, right? So answer in this case is going to be what? This is going to be the answer number D. This is going to be the answer number D, which is going to be the answer here, right? What are the other important points that we are having? If you can summarize here, we have the space, we can summarize. What is the most common obsession? What is the most common obsession? I'm just talking about the obsession. So obsession is the most common obsession of contamination. Obsession of contamination is the most common obsession. What is the most common compulsion? Most common compulsion. What is the most common compulsion that we are having? What is the most common compulsion? Compulsion is compulsion of checking. Compulsion of checking. Like you must have seen lots of people, they go out and then they will come back to home just to check whether the lock is there, yes or no, right? They will check whether lock is done or not. They are going to look for the keys again, they will go back, they will check. So this is the compulsion of checking, is the most common compulsion. You will be having that obsession development in the body, and you will be always be like, okay, let me go just once and let me see whether this thing is done or not, right? This is the compulsion of checking, right? How you are going to treat these patients? Treatment for OCD, the treatment will be what? Treatment will be behavioral therapies. We are going to give BT here, and we can also do exposure and ERT, basically exposure and response prevention therapy. We can also do exposure and response prevention therapies, right? So we are going to expose the patient to certain kind of obsession, and then we are going to prevent the compulsion. We will let the patient sit in front of us, and this is going to be the exposure and response prevention therapy. Okay, so this is going to be the thing. Answer in this particular case is going to be D. What is the next question we are having? A 26-year-old male patient is presented to the OPD. Okay, OPD, and he has a history of a road traffic accident. He had a road traffic accident earlier in the past, and now this patient is coming with the complaints that he is afraid to see a truck. He is afraid to see a truck. He is having some kind of a disorder, right? And looking at the truck, he runs away as he thinks the truck will hit him. He will think like that the truck will hit him, and this particular thing is going to affect his life. Okay, so he is having some previous history is going to be there, and this patient is having what? This patient is having this particular problem in his mind, right? So what is happening? This is a patient who is coming to the OPD with the symptoms. What is going to be your answer? What do you think? What should be your answer? So here you will be having history of road traffic accident in the past, and now this patient is afraid to see the truck. As soon as he see the truck, he will think like that, okay, this truck is going to hit me hard again, and this is affecting his life. So what is going to be the answer? Yes, very good, Saranyamol, right? That is going to be what? That is going to be delusion of reference. Delusion of reference can be there. Delusion of reference means what? People are referring him. People are referring me. So two people are talking, they are referring me. That is going to be the delusion of reference. Delusion of persecution means what? This is the most common type of delusion. People are trying to harm me. Delusion of grandiosity, that means he is the superior one. He is the superior one. He is the god. That is known as the delusion of grandiosity. Lastly, we are having PTSD. What is PTSD and what are the symptoms he is having? As soon as he sees the truck, what is happening in his body? His body will be having the anxiety. He will be having the anxiety. What are the symptoms? He will be having tremors. He will be having those palpitations. He can have tremors, he can have palpitation, he might have sweating, and these are going to be what? These are going to be the symptoms which are going to have the irrational fear. Irrational fear means this is non-justifiable. You see a truck, you had an accident, and now you see a truck and you are afraid of the truck, right? So this is going to be irrational and extreme fear. You have, when you have a irrational and extreme fear, this is going to be termed as what? This is going to be a symptom of anxiety, right? And if you are having the history is going to be present, and if you are having the past traumatic event or some kind of a stressful event, this is definitely going to be what? This is definitely going to be PTSD. This is definitely going to be PTSD. But what about PTSD? You will be having 3-4 important things about PTSD. So let's try to understand what are the things we are having post-traumatic stress disorder. Here you always have the intrusive symptoms. So when you close your eyes, intrusive symptoms means what? So जब आप आंखें बंद करोगे, when you are going to close your eyes, you will be having those flashbacks. You will be having those flashbacks. So these are going to be the intrusive symptoms. So when you close eyes, when you close your eyes, when you close your eyes, you will be having what? You will be having the flashbacks. You will be having the flashbacks, right? So you can have the flashbacks of that particular incident that has happened. This is going to be known as intrusive symptoms. Second symptoms are going to be arousal symptoms. Arousal symptoms means as soon as you think about it, you close your eyes, or maybe you think about, you see a truck, you will be having arousal symptoms, that you will get excited, you will be like you will become hyper vigilant. More appropriately I can say, you will become hyper vigilant, you will become more active, you will look around, okay sir, this thing can happen, okay beta, right? So this is going to be the arousal symptoms. Apart from intrusive symptoms, arousal symptoms, you will be having avoidance symptoms also. That means this patient, you are going to tell this particular patient, okay, let's go to party, let's go for a long drive, let's go somewhere out of the city, let's go for a ride. So what this patient is going to do, he's going to trying to avoid, he's going to have the avoidance symptoms, though he is going to trying to avoid such situation where he will be having encounter with the truck, right? So he is going to trying to avoid such situation. This is going to make what the, this is going to complete the criteria for post-traumatic stress disorder. That means this patient will be having intrusive symptoms when he can have the flashbacks. Simply you can remember, intrusive symptoms means he will be having the flashbacks, he will be having arousal symptoms. That means this patient is going to become hyper vigilant around for the things, he will be more active, he will be more active, right? He will be having avoidance symptoms also. These are going to be the symptoms of this particular disease. This is going to be the PTSD, post traumatic stress disorder, right? The next one in the question, next one on the list, we are having a 23-year-old female patient, and she's coming to hospital with the symptoms of sadness of mood, and she is experiencing a reduced sense of enjoyment. She does not feel good in activities which were previously pleasurable, and this is happening from last 1 month. This is happening from the last 1 month. So she is not feeling happy about the things and which were previously pleasurable, and this particular thing is known as what? This particular thing is known as, it is a negative symptom that we are having in front of us, and this is known as anhedonia. Remember, these are the patients which are going to come to you in the hospital. They'll be like, sir, I used to be happy earlier, and now earlier I used to play basketball, and I used to go out, I used to do shopping, I used to watch movies, but now I'm not feeling good when I'm trying to watch movies. I'm always wanted to sleep, I'm having sadness of mood, I don't want to talk with people, I just want to leave alone, right? So these are going to be the symptom, and how you will examine this particular patient, she will tell you that these symptoms are present in me with from last 1 month. So how you are going to suspect what is the thing that can happen, right? Are you going to write a CT scan? That is going to be truly a wrong thing to do, right? So we are not going to do any CT scan over here, we are not going to do even any MRI over here. So what is this MSC and what is this MMSC that we are going to follow, right? What is this MSC? MSC is the mental status examination. This is the type of clinical examination that we are going to do. This is a clinical examination. Clinical examination means maybe a clinical psychologist will try to understand what is the problem with this particular girl. This is just a 23-year-old girl, and she does not want to go out, she does not want to talk with other people, right? So this is how we are going to understand. What is this MMSE? Mini mental status examination. MMSE is what? This is your mini mental status examination. This is your mini mental status examination, and this is what we are doing MMSE we are doing to identify organic mental disorders. To identify the organic mental disorders, we are going to do what? MMSE, like organic mental disorders like dementia. Someone is having dementia, we can do this MMSE, right? Here you will be having you will be checking for, it will be having on 30 points. This MMSE will be having how many points? 30 points. Okay, more than 25 is going to be normal. More than 25 is going to be normal, and less than 24 score is going to decline the situation. Like if someone is having the score coming out to be around 10, that means this patient is having severe damage will be there, right? So this is how we are going to assess our patient on the basis of MMSE, right? This is the mini mental status examination. But what about this MSE? What about this MSc? What are the components of this MSc? This is what we are going to see. These are going to be the components of MSc. What are the components? These are going to be the components. First thing we are going to see is the general appearance of the patient and behavior of the patient. We'll look at the patient. We will try to understand, okay, this patient is well dressed, this patient is not well dressed, this patient is having increased in the speed of thought, and all those things we are going to see about the speech. Like I told you, what is the speech disorder, what is the thought disorder, what is the speech disorder? Like speed will be increased, that means what? She can have mania. Decrease in the speed means what? She can have the symptoms of what? She can have the symptoms of depression. Okay, we can check for the mood or affect of the patient. Mood is a long-term thing, affect is going to be a short-term thing. Mood is a long-term thing, whereas affect is going to be a cross-sectional thing, right? So we can check the mood or affect of the patient. This is going to tell us about the emotions of this patient, why this patient is sad, what are the things which are happening. You can understand from the general appearance of the patient that she's by dressing sense you can understand what is the mental state of a person, right? By speech you can understand whether she is having mania or depression. By mood and affect you can understand the emotions of the person. By thoughts, what are the thoughts she is going to have? This is going to tell you about a lot of things. Thoughts are going to tell you about a lot of things. Okay, emotions are also going to tell you about a lot of things. She'll be like she is sad, she is happy, she is angry. Like emotions are generated. Well, can anyone tell me where is the generation of emotions? Emotions are generated where, and emotions are controlled by what? You always say I love you, you always say I hate you, you always say I'm angry with you. All these emotions are generated where? Remember, there is no emotion coming from your heart. The emotions are generated where? They are generated from your limbic system. Whereas these emotions are controlled by your frontal lobe. So there is a possibility this patient might be having problem with the frontal lobe also. When you have problem with the frontal lobe, what will happen? Whatever comes in her mind, she will speak. That is going to be what? That is going to be, there is a problem with the frontal lobe. There is a problem with the frontal lobe, that normal individual, like in my mind lots of things are coming. Do I speak everything? No, I'm going to have that filter because my frontal lobe is intact. I'm going to stop those specific things, what I need to tell, what I need not to tell. I will judge on the basis of that, and then I will speak, right? So this is going to be the frontal lobe. Some people are having issue with the frontal lobe. They will speak whatever comes in their mind. So this is going to be the thing. You can have delusion, or you can have perception disorder. Perception means what she is perceiving. She can have perception disorder, like I told you, perception disorder is going to be illusion and hallucination. So we can understand about the illusion and hallucination. Okay, cognition means what? Cognition is the same thing that I explained just now. Cognition, if your cognition is intact, you will know what to speak. If your cognition is not intact, whatever comes in your mind, you will speak, right? That is going to be the cognition. Like if we catch a terrorist, you know what we are going to do? We are going to inject some scopolamine or some truth serum. Those drugs are going to do what? Thiopentone or scopolamine. Those drugs are going to decrease the cognition of the person. Now person is not able to remember what he is saying. He will only speak the truth, right? You go to a train, and in train some people are going to give you dhatura seeds along with the sweets, right? They are going to mix those dhatura seeds along with the sweets. And what is going to happen when you are going to eat those dhatura seeds? What is going to happen to you? When you are going to eat those datura seeds, you will be having decrease in the cognition. And decrease in the cognition will lead to what? You are going to tell now that thief is going to ask you where is the gold, where is the money, and your cognition is decreased. Your cognition is decreased. You will automatically tell yourself I've kept all the money over there, I've kept all the gold over there. That is why your family is telling us, family is telling us not to eat anything outside, right? What about the judgment? We have already seen the judgment. You will ask the patient what you will do if a tiger is going to come behind you, and the answer is going to tell us about the judgment of the patient, right? Judgment is going to be a thing which we are going to check. We are going to check not just judgment but also the attention or concentration. Also the attention and concentration, how you can check the attention of a patient. Attention and concentration of a patient. Attention and concentration we can check. If I tell you something and I will tell you to repeat that same word, this is how I can understand whether you are attentively listening to me or not. How can I check the concentration? We are having 100 minus 7 serial subtraction test. I will tell the patient to subtract this. If patient is attentive, patient is concentrated, then I will check for the judgment. And insight is what? Insight is the awareness of the disease. Insight is the awareness of illness. So I'm going to understand whether this patient knows about his illness, whether this patient knows about her illness. So these are the component of what? Mental status examination. These are the things we are going to see in the mental status examination. You understand this? What is mental status examination? So any patient who is going to come to us, I'm going to assess what? I'm going to do a MSc. I'm going to do a MSc, and in this particular MSc I'm going to see the appearance of the patient, behavior of the patient, speech of the patient, how he is talking. I'll check for the mood of the patient. What is the mood of the patient? Maybe he is angry, maybe he is sad, maybe he is in the love, right? So mood or affect of the patient, I'm going to understand. Thoughts, what are the thoughts of the patient, what are the thoughts disorder he is having, right? We can understand that. Formation of thought will be like this patient might be having derailment, this patient might be having tangentiality. The same things we have discussed above, these are the thoughts, right? These are the thoughts. Like I will check for the flow of thought, I will check for the content of the thought. Maybe this patient is coming to me and she is telling me that I am the god. Yeah, who are you to take my examination? How can you ask me those questions? So this patient might be delusional, right? You can have formation of thoughts, like this patient will be telling me word salad and I'm not able to understand what she wants to convey, right? This patient will be telling me some neologism, I will understand, okay, this patient might be having schizophrenia. What about the position of thoughts? I'm going to understand. She will come and tell me, okay sir, I'm having some my neighbors are just trying to put certain thoughts into my brain, my neighbors are conspiring against me. This is going to be delusion and this is going to be thought insertion. So this is how we assess our patient, and this is how we will reach to a particular diagnosis that this patient is having this particular disease, and we will have to give the treatment accordingly, right? So this is going to be the question, and in this particular question you are going to do what? Mental status examination of the patient, right? Next thing we are having is about the 32-year-old male patient is presented to the OPD with his wife. This patient is presented to the OPD with his wife. The patient is telling that he is in love with Alia Bhatt, right? And she is also loving him badly with her wife. When her wife asks for the proof, he tells that someone has hacked their mobile phone and they don't let anyone else to see the proof, right? Yes, it is going to come under the form of thought, right? Which of the following explains the condition of the patient? Which of the following explain the condition of the patient? What is the thing we are having over here? What is the diagnosis over here? What do you think this patient is having? This patient is having Cotard syndrome. This patient is having de Clembert syndrome, Othello syndrome, or Bobbitt syndrome. What is going to be the diagnosis over here? What do you think is the diagnosis over here? What is going to be your diagnosis over here? Okay, de Clembert is the right answer. So let's try to understand what is this the patient is having. This patient is thinking like that he is having Alia Bhatt as a, like in news also you're finding that someone is claiming that my mother is like Aishwarya Rai is my mother. So they are having some kind of a disorder in the brain, right? What is this particular thing? That this patient is coming to this 32-year-old male patient is presented to the OPD with his wife. Our wife is bringing this particular patient, and he's like, okay, Alia Bhatt is my girlfriend, we are loving each other very badly. And when a wife asks about the proof, and he will be telling you someone has hacked our mobile phone, maybe Ranveer has done something, and he's not allowing us to see the conversation, right? So that is the thing we are having. So this patient is having a firm and fixed belief, which is unshakable. This is going to be the diagnosis. The diagnosis in this particular case is going to be what? Delusion. The diagnosis in this particular case is going to be what? It is going to be delusion. What is this Cotard syndrome? This Cotard syndrome is also known as nihilistic delusion. This Cotard syndrome is also known as nihilistic delusion. We have also seen this. This is also known as delusion of negation. Delusion of negation, that means very negative. This person will be having delusion that he don't have. He's having the hand, but he's having the delusion in his brain that this hand does not belongs to him, right? Delusion of body part can be there. Delusion absence of body part can be a delusive thought. Body part, he will think like that this is not his body part, he don't have arm like that. Okay, so this is going to be nihilistic delusion. What is this Declambered syndrome, also known as fantasy lover syndrome? This is also known as fantasy lover syndrome. This is also known as fantasy lover syndrome, also known as erotomania. This is also known as erotomania, where a particular person from a higher socioeconomic status, when a person, or you can say a person from lower socioeconomic status, lower socioeconomic status will, when a person with lower socioeconomic status will fall in love with a person of higher socioeconomic status, like in this case higher socio-economic status, right? This is going to be what? This is going to be a case of fantasy lover syndrome or Declambered syndrome, or also known as erotomania. Just speak the name. These are going to be Declambered syndrome. These are also known as erotomania. This is also known as delusion of love. This is also known as lover syndrome, fantasy lover syndrome. Next one we are having is Othello syndrome. Othello was a novel by Shakespeare, right? So this is also known as delusion of infidelity. Delusion of infidelity. Delusion of infidelity. Here this patient is having what? Delusion of infidelity, also known as morbid jealousy. Delusion of morbid jealousy, delusion of infidelity, delusion of morbid jealousy. You can also call, in certain books it is written, pathological jealousy. This is also known as pathological jealousy. Or this cases you will generally find with the alcoholic patient, and this alcoholic patient will come and they will think like that his wife is having some this wife is having some other affair, and he's not going to believe. This is a delusion. And delusion, you already know that this patient will be having what? This patient will be having a false and firm belief. The false and firm and fixed belief. That means he's not going to accept, even if you show all the proofs. He will be putting all the CCTV. She's sitting in front of the CCTV all the time. Still, he will think like that she's doing some kind of a wrong thing. This is known as delusion of infidelity. We are also having a novel of Othello syndrome, right? This is also known as morbid jealousy. This is also known as pathological jealousy, right? And lastly, we are having what? Bobbitt syndrome. This is going to be a syndrome where this female is going to do what? Female is going to cut the penis of male partner, right? This is known as Bobbitt syndrome. इसको क्या बोलते हैं? This is known as Bobbitt syndrome. So we are having this four things here, and in this particular case, this patient is having a type of delusion. This patient, the diagnosis in this case is going to be a type of delusion. And what type of delusion? Is it a delusion of negation? Is it a delusion of fantasy lover or erotomania? Yes, sir. He is having D. Clembert syndrome. In examination, they will be writing you options like this only: D. Clembert, Cotard, Othello, and Bobbitt syndrome, right? So you will be getting confused. So remember here itself, D. Clembert is what? It is also known as fantasy lover syndrome. It is also known as erotomania. Cotard is what? It is also known as nihilistic delusion, also known as negation, delusion of negation. What is this? Othello? It is also known as morbid jealousy, pathological jealousy, generally seen in alcoholic patient who are going to think like that her wife or maybe her husband is having his husband is having the particular thing, right? So that is going to be the delusion of infidelity, right? Now comes the next question, very important question. A 29-year-old female patient is presented to you by her husband, and the lady has delivered a baby few days ago, 6 days ago, by normal vaginal delivery. And now the husband is complaining that she is crying all night. She is crying whole night. She could not sleep, and she do not eat anything also, right? And she is always feeling very low. She is feeling very low. General physical examination of these patients are normal, and no other findings were there. Which of them will be the best describing this particular condition? Is it a postpartum blue? Is it a postpartum depression? Is it an anxiety case? Is it a psychosis case? Okay, postpartum blue, anxiety, depression. What are the symptoms we are going to have over here? This patient is having symptoms of insomnia. This patient is having symptom of insomnia. That means she's not able to sleep. This patient, we are finding that symptoms are looking like a depressed kind of symptoms. Okay, and she's having an increased in the emotional reactions. She is crying all the night. This is going to be increase in emotional reactions. So all these symptoms are there. They are going to be the symptoms of what? Let's try to understand what are the postpartum blues, what is a postpartum depression, what is a postpartum psychosis. So let's try to understand this. What is postpartum blues? Blues are going to be happening, remember, within 1 to 2 weeks. This is going to happen within 1 to 2 weeks. All these things are going to be complications you will be finding postpartum. Partum means post delivery. Postpartum means post delivery. You will be having these symptoms, and these symptoms are due to what? Progesterone. You understand what is progesterone? Progesterone is a hormone. Every month the female is having what? Female is having what? Increase in the levels of progesterone, right? On 14th day you will be having ovum coming out, and after that you will be having what? After that you will be having that corpus luteum is going to increase your progesterone, and till the time this progesterone will be there, till the time the period is about to come, or basically the menses is about to happen, till that time you will be having high levels of progesterone. So progesterone is a hormone which is going to depress your brain, which is going to keep you depressed, which is going to soothe your brain, right? As soon as you will be having what? As soon as you will be having decrease in the levels of which is going to sedate your brain. So as soon as you are going to have what? Loss of this progesterone, what is going to happen? You will be having irritability in the mood. You will be having mood swings, right? That is the loss of progesterone is the thing which is going to cause what? Mood swings. Loss of progesterone is the thing which is going to cause what? Mood swings in the females, right? So around the time of period she will be having mood swings, and that is what is indicative of what? She will be having this particular thing, right? So the same thing is also going to happen after the delivery. Till the time the delivery, till the time of the delivery, what is going to happen? You will be having thick myometrium will be there, and basically you will be having high levels of progesterone. As soon as you deliver the baby, what is going to happen? You will be having the decrease in the levels of progesterone, and that is the progesterone which is going to be responsible for all these particular problems, right? So in the postpartum blues, this postpartum blues are going to happen generally in the first 2 weeks of the postpartum, right? And symptoms are going to be again irritability, anxiety, fluctuating mood, increased emotional reactivity. These are going to be the same symptoms, right? These are going to be the mild symptoms, and they are going to this is not going to be considered as a psychiatric disorder. They will be automatically corrected, right? This is going to be the postpartum blues. Whereas this postpartum depression, when this thing is happening for such a long time, right, this thing is going to happen for a long time, like a year, this is known as postpartum depression. Like after depression, 13% females will develop this particular thing for the first year, right? Symptoms are going to be excessive guilt will be there, anxiety, anhedonia, depressed mood, insomnia, hypersomnia, suicidal thoughts, and fatigue will be there. Okay, so moderate to severe symptoms will be there, and prolonged course will be there. Here we need to give treatment to this particular female. Whereas this postpartum psychosis, psychosis means what? Psychosis means this is going to be a severe thing, and this thing is going to happen like 2 to 12 weeks, or in certain books it is written 2 to 8 weeks also, right? So this is going to be an entity which is going to happen in the first 3 months or 12 weeks, you can also remember, right? 8 to 12 weeks, or basically first 3 months of the disease, this is going to happen. Here you will be having what? Here you will be having rapid cycling will be there, agitation, delusions can happen, patient can have hallucination, the psychotic symptoms can be there, cognitive impairment will be there, this patient is having low insight, right? So this is going to be a severe thing, and it requires your psychiatry, it is a kind of a psychiatric emergency, and you need to hospitalize the patient here, right? So we are having three things. 1 to 2 weeks is going to be postpartum blues, 8 to 12 weeks is going, or 2 to 12 weeks is going to be postpartum psychosis, and this is going to be postpartum depression, postpartum depression. So in this particular case, we are having the time period that is given is only 6 days, right? So this is going to be postpartum blues. Everyone is right, this is going to be the postpartum blues that we are having, right? Now comes the next question. Next question we are having is another question. This is going to be: a 17-year-old girl is presented to you with the complaints of excessive exercising and dieting, right? 17-year-old girl, she's doing what? Excessive exercising and dieting, and along with the irregular period, right? On further examination, the patient is having what? Callousy knuckles will be there, and BMI of this patient is what? 17.5. BMI is 17.5. She's decreasing the, she's dieting means what? She's decreasing the volume of food, she's decreasing the volume of food, right? She's not eating good food. And what is the normal normal BMI? So you can remember, normal BMI is going to be what? Normal BMI is 18.5 to 24.9. Normal BMI is going to be 18.5 to 24.9. So what is going to happen in this particular case? We can have three diseases that are more common. One is going to be anorexia nervosa, second one is going to be bulimia nervosa, and third one is going to be binge eating disorder, which is in fact one of the most common type of disorder, right? Eating disorder. Here this patient, binge eating patient, will be eating, this is the most common disorder. Binge eating means he is going to eat whatever comes in his plate, right? So this is going to be the binge eating disorder. Can you appreciate? This patient is a mota patient, this patient is a thick patient, right? So this is the most common eating disorder, and this can lead to the symptoms like this patient can have diabetes, this patient can have high blood pressure, high cholesterol, heart diseases, stroke, they can have certain cancers, gallbladder diseases, depression, anxiety. All these symptoms are due to eating a lot of food, right? These things can happen, right? When you eat food, you eat food, what will happen? All the amino acid are going into the cells. The only which is going to be come out is going to be what? Serotonin. And this is the serotonin, it is going to come into the blood circulation, and when this serotonin is going into brain, what is going to happen? Serotonin into brain. Serotonin is the happy hormone, so that is why you are going to feel what? Happy. And to make you feel happy, every time you need to eat more food, every time you need more serotonin. This is also a type of addiction. This is also a type of addiction. This is the basic pathology behind it, right? So when you eat food, you will be having this serotonin kick. This serotonin will go to your brain and you will be feeling happy. So every time you eat a good food, what is going to happen? You go outside, you get ready, you go outside and you eat good food, good life, right? So that is what is going to happen when you have this good food, right? So this is going to cause what? addiction, right? So this is the most common disorder. Now some people are having this particular disease, that is going to be, these people are having what, this is a thin patient, this is a thick patient, right? So this is going to have bulimia nervosa patient will be have weight is going to be normal. This patient is going to have what, normal weight will be there, whereas anorexia nervosa patient will be having decrease in the weight. She's not going to eat anything, she's going to decrease the food intake, she's having some dysmorphia, right? She's going to have some self image will be distorted, right? So she will be always thinking like that she's fat, and she will always try to decrease the weight. She will try to decrease the weight, she will put the hand inside and she will do what, purging. She will do what, purging. And because of that, what is going to happen, she is going to have the callousy knuckles. She can have the callousy knuckles because of that, right? So what is going to be explaining this particular fact, that this is going to have what, anorexia nervosa. This is a patient of anorexia nervosa. She is going to be a thin patient, and because of decrease in the fat, you will be having irregular periods also. Irregular periods, like you can see, just I'm giving you verbal explanation. Have you seen some chubby females? Chubby females are going to get what, early puberty. Chubby females are going to get early puberty, right? Whereas those females who are going to be very very thin, they are going to get delayed puberty. Delayed puberty, right? And this is all these things are happening because of a hormone. This is known as leptin, and leptin is going to tell us about the, leptin is going to tell us about the what, it is going to tell us about, it is going to tell us about the adequate fat storage. Adequate fat storage. So when your body is going to have adequate fat storage, you will be having what, you will be having good menstruation, everything will be fine. So when your body does not have adequate fat storage, you will be having what, you will be having delayed in the puberty. Pubertal signs will be delayed, right? You will be having delayed in the thelarch, menarche, pubarch, everything will be delayed, right? So that was the question. Now comes the next question. We are having a 19-year-old girl is brought to you in the OPD with the complaints of recurrent episodes of increased cardiac contractility. She is having recurrent episodes of increased cardiac contractility, sweating is there, insomnia is there, and there is problem in the breathing beta. Okay, when she feels this symptom, she is having a feeling of impending doom also. What is this impending doom? She feels like she is about to die. What is the likely diagnosis for this particular condition? A 19-year-old girl. So let's try to understand this. What are the symptoms you are appreciating over here? This is a very young girl. This is a very young girl. This is 19-year-old girl, and she's brought to the OPD with the complaints of recurrent episodes of increased cardiac contractility. Increased cardiac contractility means what? This is considered as palpitation. Palpitation means what? What is palpitation? What is tremors? Palpitation is increased cardiac contractility. This is known as when your heart is pumping too much. This is known as palpitation. When you have excessive contraction in the cardiac muscle, this is palpitation. When you have excessive contraction in the skeletal muscle, this is known as what? This is known as tremor. This is known as tremor. So you can have palpitation, you can have tremors over here. So here tremors, palpitation is given. You are also having what? Sweating is there. She is having sweating. She is having insomnia. She is not able to sleep. She is having insomnia. She is having physical symptoms of, these are the symptoms. Which are the symptoms? These are the symptoms of problem in breathing. This is going to be dyspnea. These are the symptoms of which disease, where you will be finding these symptoms. She is a young girl. She cannot have MI or something like that, but she can have a very common disease, which is going to be your anxiety. This is going to be your anxiety. And whenever this anxiety is there, and along with the anxiety, they are writing you impending doom. Impending doom. These are the normal symptoms of anxiety. When they are going to write along with the anxiety impending doom, this is going to become what? Intense anxiety. This is going to become what? Intense anxiety. And this intense anxiety is known as what? Panic attack. This is what is known as panic attacks. So now you know what is panic attack, what is anxiety. Anxiety is the normal symptoms like that. So whenever these symptoms are given, and along with these symptoms you have written what in the question, they are going to write you impending doom. You will be thinking about what? This is a case of panic attack. This is a case of panic attack. And remember, when this panic attack is going to be recurrent, when this panic attack is going to be recurrent, this is going to become what? This is going to known as panic disorder. This is known as panic disorder. So this is the panic disorder we are having over here. This is panic disorder we can have over here. So here it is already written, this is patient is having recurrent episodes of such type of effect. Okay, so this is going to be what? Now your answer will be what? Now your answer will be, is it a panic attack? Is it a panic disorder? Is it a generalized anxiety disorder? What is this generalized anxiety disorder? If anxiety is going to be there for more than 6 months, okay, or more than 6 months, anxiety is there for 6 months, or maybe more than 6 months. 6 months is the cutoff. 6 or more than 6 months, more than 6 months, this is going to be known as generalized anxiety disorder, where you will be having normal anxiety, tension. This patient is having the tension, this patient is having always, this patient is anxious, right? What is this PTSD? We have discussed PTSD will be having a stressful event. After a stressful event, if the patient is having this type of symptoms, this is known as PTSD. And after 6 months, if after 6 months of this stressful event, if someone is having this type of symptom, this is known as delayed type of PTSD. Delayed PTSD. This is known as delayed type of PTSD, right? So if someone is having those stressful event, and the patient is having the symptoms like 3 symptoms I've told you. What are those 3 symptoms? Arousal symptoms, hypervigilant symptoms will be there, intrusive symptoms will be there, right? This is going to be a PTSD. This is going to be a PTSD. If this PTSD is happening after 6 months, this is known as delayed PTSD. Okay, normal anxiety, you will be having palpitation, you will be having sweating, you will be having dyspnea, you will be having insomnia, not able to sleep. This is going to be your normal palpitations, normal anxiety that is going to happen. This is going to be anxiety. If it is happening very occasionally, it is fit and it is fine. It is a normal bodily protective response, right? You have something to do, you need to go to stage, you need to speak in front of 1,000 people, you will be having anxiety. This is a normal response. But when this anxiety is going to have with the feeling of impending doom, that something is about to come and I'm going to collapse, this is going to be known as intense anxiety. This is known as panic attack. Now this patient is having what? Panic attack. And when this patient is going to have recurrent such episodes, in the question they have mentioned recurrent such episodes, this is considered to be as panic disorder. This is considered to be as panic disorder, right? So in this particular case, what is going to be your answer? This patient is having panic disorder. This patient is having recurrent such episodes. So answer in this case is going to become panic disorder, right? The next question we are having is what? A 45-year-old patient is having issues with the neighbor. He is having issues with the neighbors, right? From the last 5 years, he always thinks that they want to harm him. Same delusion is going on. And he also hears some voices. Voices means hallucination, which are inaudible by others, right? And diagnosis of schizophrenia was already made. Okay, no issues, right? And he was started on haloperidol, and haloperidol is an antipsychotic drug. After last night dose, his eyes are rolled up. Now his eyes are rolled up after the last night dose. Maybe he has done the overdosing. For few hours he was brought and then he was brought to the emergency department. And what is the drug which is going to what should be given to the patient right now, right? So patient is brought to the emergency department. What are the symptoms they have given you? These are the symptoms, like patient is having delusion of persecution. First thing, persecution, right? Second thing, patient is having auditory hallucination. Third thing, this patient is going to have the diagnosis. Because of that, this patient is having diagnosis of schizo. After getting the diagnosis of schizophrenia, right, what we are going to do, this patient is having the diagnosis of schizophrenia. After having the diagnosis of schizophrenia, we are writing a drug to the patient that is going to be haloperidol. Haloperidol is an antipsychotic. We are having two types of antipsychotic. We can have first generation antipsychotic, we can have second generation or second generation antipsychotic. So first group of drugs we are having, they are going to be working specifically on D2 receptor. They are going to be known as typical antipsychotic, whereas they are known as atypical antipsychotic. This typical antipsychotic is going to work on D2 receptors directly, and this D2 receptor, they will be inhibiting, right? They will be working more on D2 receptors, and what are going to be the side effect? They will be causing extrapyramidal symptoms. Extrapyramidal symptoms, and they can be effective against positive symptoms. So whenever a patient is having positive symptoms, what are the drugs which are going to be more effective? They are going to be first generation or typical antipsychotics. If the patient is having more of a negative symptoms, we are going to use second generation drug. This is going to be atypical antipsychotic. They will be having D2 inhibition property, but they are also having 5-HT2A inhibitor property also, right? This is going to work better against negative symptom. And now you already know what is negative and positive symptoms. Negative symptoms are like anhedonia, apathy, alogy. They don't want to talk to anyone. Asociality. They don't want to go up. They don't want to see anyone. These are the negative symptoms. And in these cases, which drug is going to be working better? These are going to be atypical antipsychotic. These are going to be atypical drugs which are going to be working better. And what is the side effect of these drugs? These drugs are going to cause metabolic side effects. Like patient will be having weight gain. Metabolic side effects can be there. Patient can have weight gain. Patient can have hyperlipidemia. Hyperlipidemia can happen. Patient can have weight gain. So these are going to be the common side effect with the second generation drug or drugs which are going to be atypical antipsychotic. Now, what is this EPS? They are asking question based on the EPS. They are asking question based on the EPS. What is extrapyramidal symptoms we are having? These are going to be your extrapyramidal neurological symptoms that we are having. The first one we are having is going to be acute dystonia. Dystonia is going to be there, and this dystonia means what? It is the earliest side effect that occurs during 1 to 5 days of the drug administration. Drug initiation के 1 to 5 days में हो जाएगा, right? It is going to happen within 1 to 5 days. Here you will be having uncontrolled muscle spasm, mostly over tongue or neck or face, and this is going to be the earliest side effect that we can have. They are asking question from here, and how you are going to treat that, that is also they are asking. So earliest side effect is going to be acute dystonia. Abnormal tone will be there, and the symptom that we are having over here in this particular question, that is going to be rolling of eyes or torticollis. These are the symptoms because of this acute dystonia, right? What is the drug would you like to administer? This is going to be the treatment. Here we are going to give what? Promethazine to the patient, or we can also use benzoxazole. This is going to be the drug of choice for acute dystonia. But the second thing we are having is Parkinsonism. Parkinsonism, what is going to happen? Why this Parkinsonism is happening? Parkinsonism is due to decrease in the dopamine in which pathway? Now you already know this is going to be nigrostriatal pathway. So decrease in dopamine in nigrostriatal pathway because you are giving a drug which is going to block what? You are giving a drug which is going to block what? Dopamine, right? So you will be having decrease in dopamine in nigrostriatal pathway also, and you will be having these symptoms within 1 to 4 weeks of drug initiation. And these symptoms are same: bradykinesia, tremors, rigidity. This patient will be taking baby steps. This patient will be having rigidity. This patient will be, have you seen Muhammad Ali? This patient is having, Muhammad Ali is having what? He is having the Parkinsonism. So he will be taking those baby steps, right? Tremors can be there. So in this particular case, we are going to give, this is going to be the Parkinsonism, and this Parkinsonism is going to be drug induced Parkinsonism. Drug induced Parkinsonism, right? Next you can have akathisia. This is going to be the most common symptom. Akathisia. Akathisia means you will be having restlessness in the patient. Okay, irresistible desire to move around. This patient will be going here and there, right? This is known as akathisia. This patient will be moving here and there, and the drug of choice is going to be propranolol. Drug of choice is going to be propranolol. Next is going to be your neuroleptic malignant syndrome. This is going to be a serious complication that can happen, and the drug of choice for neuroleptic malignant syndrome and drug of choice for one more thing, that is malignant hyperthermia. Both of them are going to have the same drug of choice, that is going to be IV sodium dantrolene. Okay, IV sodium dantrolene. And tardive dyskinesia is a chronic complication. It is a late side effect that will be happening after months to years, right? And here the drug of choice will be what? Here the drug of choice will be valbenazine. Valbenazine. This is what you are going to give in the cases of tardive dyskinesia, right? So these are the extrapyramidal symptoms. What are the extrapyramidal symptoms? Just repeat after me. We are having the most common is acute dystonia. Second one is Parkinsonism. Third one is akathisia, that means abnormal movement. Neuroleptic malignant syndrome, where you will be having excessive of calcium release leading to muscle rigidity, fever, high BP, myoglobinemia, right? So that is going to be neuroleptic malignant syndrome. Drug of choice is going to be IV sodium dantrolene. And this tardive dyskinesia is, tardive means long term. It is going to be a long term complication where you will be having painless movements of faces and upper limbs. This is going to be the thing we are having. Drug of choice will be valbenazine, right? So in this particular case, what was happening, our patient, we are giving what? Haloperidol. And after giving haloperidol, what is the side effect you can expect? You can expect the side effect that is going to be the most earliest or most common side effect. Out of these two, anyone can happen, right? Out of these two, this is going to be the acute dystonia, which is going to be the most common. And treatment for this particular acute dystonia is going to be promethazine. You will be administering in the hospital with the name, it is coming as Phenargan. Okay, you are giving someone this injection haloperidol, you are also giving what? Promethazine. And this promethazine is nothing but the Phenargan injection that you are using, right? So this is going to be the promethazine. Okay, now comes the next question. A 32-year-old male patient who is coming, who is a known case of generalized anxiety disorder, right? Patient is presented to emergency with the complaints of impending doom. Complaints of impending doom. The preferred drug for this particular patient would be, so I've given you, patient is having what? Generalized anxiety disorder is already there. This patient is having anxiety, and now along with the anxiety, this patient is having feeling of impending doom. And whenever this patient is having feeling of impending doom, it will become what? It will become panic attack. It will become panic. It will become the panic attack. And in the cases of panic attack, what would you like to administer in this particular patient? Would you like to give propranolol? Would you like to give paroxetine, fluoxetine, or alprazolam? If I ask you what is the most common group of psychiatric disorder? Most common group of psychiatric disorder. This is going to be the anxiety disorder, obviously. This is going to be the anxiety disorder, right? If I ask you most common psychiatry disorder, then your answer will be changed. Most common psychiatric disorder, then your answer will be specific phobias. People are having a lot of phobias, right? So this is going to be what? Specific phobia. Specific phobia is going to be there, right? So how you are going to identify this particular thing? The patient is having what? Panic attack. And these are the people, they are going to come to you in emergency. Definitely you need to identify this patient. If a patient is coming in the daytime normally and always complaining to you, sir, I'm having sometimes these symptoms, you will be like, okay, you have the anxiety. Since how many times you have the symptoms, you'll be like, okay, sir, I'm having the symptoms more than 7 months. Okay, you are having generalized anxiety disorder. Is there any cause behind it? You might be having some financial loss, you might be having some kind of a trauma or something like that. You need to identify the cause. Once you identify the cause, it's fine. You have the cause behind it, you treat the cause. But if you do not find the cause and this patient is having feeling of impending doom, that means this patient is having panic attack. This patient is having panic attack. And if this patient is having panic attack, you will be giving what drug out of this? You will be treating this patient. So for treatment of this particular patient, you are going to give this patient psychotherapy. First thing is going to be psychotherapy. Along with that, you are going to give this patient pharmacotherapy also. Pharmacotherapy means you are going to give drugs to this patient. Psychotherapy plus pharmacotherapy, you are going to give drugs to this patient. So what is the drug would you like to give? We are having two drugs which are going to be using over here. One is going to be for the short term and one is going to be for the long term. Remember, the drug of choice for this particular anxiety is going to be what? This is going to be SSRI. right? SSRI group of drug. This propranolol is going to be a beta blocker. This can give you symptomatic relief. Symptomatic relief can happen if patient is having palpitation. This propranolol is going to take care of the palpitation. What about this paroxetine, fluoxetine? These are going to be your SSRI. But remember, this SSRI will take some time. This SSRI will take some time. And what about this alprazolam? This alprazolam is a benzodiazepine. This alprazolam is a benzodiazepine. So in this particular case, what would you like to give to this particular patient? We are not going to give a monotherapy, right? If you start this patient on paroxetine or fluoxetine, it is not going to help this patient, because SSRI will take approximately 7 days to work, right? So till that time, you will be giving benzodiazepines to the patient. Along with that, you will be writing SSRI, right? So after 7 days, you will be having action of this SSRI will be in the blood, and you will be having the functioning, right? So what are the different drugs we are having? Antidepressant classification, let's try to understand. So this is a case of drugs which are having the antidepressant activity. This is going to be, first one is SSRI. We are having drugs like citalopram, we are having escitalopram, fluoxetine, you can use paroxetine, right? Sertraline group of drugs. These are what? SSRI. SSRI has a specific side effect. This side effect can be used in the cases of delayed ejaculation. This has a side effect. The side effect is delayed ejaculation. So if someone is having a disease of PME, what is premature ejaculation, if someone is having the disease, we can give a drug. This is going to be what? This is going to be SSRI. But as I've told you, this is going to take a lot of time. It's not like a single drug is going to treat you. Like in the cases of erectile dysfunction, you can take a single tablets, and this is going to be helping you for the erection, right? This is going to be the another thing. Here it is going to be instant relief, but here premature ejaculation, the instant relief is not going to be there. You need to have this drug for such a long time, right? Apart from that, we are having SNRI. SNRI, you can remember, NRI are going to travel in the deluxe variant. So this is going to be duloxetine, this is going to be venlafaxine. You can also have this milnacipran. Okay, milnacipran. You can have serotonin receptor agonist. These are going to be mirtazapine. These are going to be tirazodone, at atomoxetine. You are having bupropion. This bupropion is going to be also anti-smoking drug. Bupropion is going to be anti-smoking drug, right? We can also have milnacipran. Milnacirine can also be there, right? MAO inhibitors can be there. These are going to be salicyline. We can have moclobemide, right? Tricyclic antidepressant. These are going to be your commonly used amitriptyline. We can have clomipramine, called clomipramine. We are having imipramine group of drugs, and in fact this imipramine we can also use in the cases of those people who are coming to us. In fact, the drug of choice for this nocturnal enuresis is going to be what? Drug of choice is going to be desmopressin. But in hospital, if we do not have desmopressin, we can also use what? We can also use imipramine. This is also going to be effective over here. Okay, so these are going to be the classification of drugs. We are having SSRI, we are having SNRI, we are having selective serotonin receptor antagonist. We are having what? MAO inhibitor. We are having TCA, tricyclic antidepressants, right? So in this particular case, we are going to give what? Earlier treatment we need to give. What is the preferred drug for this? This patient is coming to the emergency. We need to decrease this particular symptoms. In the emergency cases, we are going to give what? Alprazolam to this particular patient, right? Now, a man was brought to the brought her wife. A man brought her wife to OPD and has a complaint that she is very shy. She is very shy and she don't speak much. She's very mature, and she is very calm since the beginning, since the day one. But what happened last week? He saw her flirting with a guy. Okay, when he asked this, she said she could not recall any of this. Okay, and during the fight, she started to talk like a child. She started to talk like a childlike voice, and started crying also, right? And what is the most likely diagnosis of this particular patient? What do you think this patient might be suffering from? There is a female. She is completely fine earlier. She is very mature. She is calm. She is everything is good, right? And suddenly she's flirting with someone else, and when his husband get to know, she's talking like a child, she's crying. So what is the thing we are having over here? Nowadays we can have anything, but what is the thing we can have over here? Out of these symptoms, out of these four things, what can be the best thing that can be suiting here? What is the best answer according to your knowledge? So here in this particular case, this is can you appreciate this particular female is having multiple personality? Can you appreciate here they want to tell us about the multiple personality disorder? So we can have this multiple personality disorder can happen. We can have depersonalization, we can have bipolar disorder, we can have depression, we can have DID. What is this DID? Let's try to understand this DID. We can have dissociative amnesia. What is this dissociative amnesia? This patient will be having certain incidents in the past. Dissociative amnesia means it is a condition when a person is unable to remember essential details from the past. Why this thing is happening? This thing is happening because of some stressful event, because of some stressful event in childhood. So how our brain is working? Our brain is going to suppress the thoughts which are there, right? Our brain is going to suppress the bad memories, right? Our brain does not want us to be in trouble, so we are having that subconscious mind. So what our brain is going to do, it is going to suppress the memory. It is going to suppress the memory. If you have suppression of memory, you will be having problem with recall in the childhood memory also. You cannot able to recall what happens in your childhood. You are going to forget. Everyone has some kind of incidents in the past, in the childhood, right? But most of us are not able to recall them until or unless we think much about it. They are automatically becoming fade, right? So why this thing is getting fade? Because our brain is doing what? Dissociative amnesia. And because of that, what can happen? You are also fading all the memories of your childhood also, right? So because of this stressful event, you are also forgetting the memories of childhood. This is going to be dissociative amnesia, right? Second one we are having is going to be depersonalization derealization disorder. Depersonalization means loss of self, खुद को भूल जाना, loss of self. This patient is going to forget about himself. And derealization means loss of world, loss of world. This person is going to have loss of world, loss of external environment. So this person is going to have depersonalization, means he will forget himself. He will think like that he is standing outside and looking at himself, right? This is going to be a type of depersonalization disorder. Derealization means he will forget where the world is, right? What is the world, what is the external environment we are having. He is going to forget everything, right? This is going to be the derealization disorder. These things are happening because of a severe stress. These things are happening because of a severe stress. Severe stress is going to be incorporated here. Next thing is about the dissociative fugue. Dissociative fugue means what? There is going to be a person who is going to travel somewhere. This person is going to travel somewhere, and after traveling to a particular part of the world, what is going to happen is going to forget all his personal history, that where he has came from, what is his name, and who is his family, right? He will forget everything and he will start a new life over there. So this person is going to travel somewhere, right? This person is going to get away, and this particular thing is known as dissociative fugue. Because of too much of stress, too much of psychological trauma, too much of stress, this patient will be having memory loss, and he will shift to a new location and he will forget about his family. Then the family will be searching. You will be finding all those posters on the streets, right? That is what is the person who is having the dissociative fugue. Dissociative fugue will be there. And what is this dissociative identity disorder? Here you will be having this multiple personality disorders that you must have seen in the movies, right? In the movies you see like a movie Aparichit, right? So what is going to happen? This Aparichit is going to have multiple identities, multiple personalities will be there, and these personalities don't know about each other, right? And also in religious beliefs we have also seen some people are having this particular thing, like the goddess is coming in the body, right? These are what scientifically, these things are what, these things are dissociative identity disorder. That means for such a brief amount of time, what is going to happen, people with DID have two or more separate personalities. Likewise in our case, the lady is going to be a good lady in the beginning, and she's talking and she don't know she's talking also, right? And in the last, what is happening, she is crying like a baby, right? So she don't know why she is crying like a baby also, right? These identity control a person's behavior at different times. DID can cause gaps in the memory, so she is not going to remember what happens with her, and other problems also. It is usually a result of some kind of a sexual or a physical abuse during the childhood, right? So these are going to be the symptoms you will be finding with the dissociative identity disorder. So right now our question is, there is a person who is bringing her wife to the hospital, and he is complaining that her wife was earlier she was calm, she was very shy, she was very mature, she don't speak much, and now she is doing flirting, she is crying like a baby, she is having multiple personality. Your answer in this particular case is going to be what? Is it a depersonalization? She's not just forgetting herself, she's having multiple personalities. So this is not going to be bipolar, this is not even depression, this is definitely a clear-cut case of dissociative identity disorder. So you understand what is dissociative amnesia? Because of some trauma you are going to forget everything about the childhood, also about the memories of childhood, they are going to be get suppressed, right? What is depersonalization? Loss of self. What is derealization? Loss of the environment. Like you see a reel, right? Some people who are watching lots and lots of movies, the thing like that, they are in the movies. Some people are watching lots and lots of enemies, like we are having a reel that is circulating nowadays where a boy is trying to do something, right? He's having what? He's having this derealization disorder. He forgot, he is watching too much of that particular enemy movies, that he feels like he is one of them, he is a part of that, right? So this is going to be derealization, depersonalization disorder. Next one we are having is about the dissociative fugue, where you will be traveling somewhere and you will lose everything that you have from your past, right? You will be starting a new life over there. You forgot who you are, where you came from, what was your name, who is your family, everything is lost. And because of a big psychological stressor, you are having this particular thing. This is known as dissociative fugue. And you can also have dissociative identity disorder, where you are going to have multiple identity disorder. This is going to be multiple identity disorder. Okay, so this is going to be the thing, right? Okay, now the next thing we are having is a non-alcoholic patient is presented to the emergency. Now the patient is an alcoholic patient. When we call a patient alcoholic, when he is having tolerance, he requires alcohol every day, otherwise he will be having the symptoms. This is going to be a alcoholic patient. Alcoholic patient means it's not like that you are drinking once in a week or once in a month, right? So this is going to be alcoholic patient who is presented to emergency department with the complaints of palpitation. He's having palpitation, and suspiciousness is there. On examination, tremors are present. On examination, we are having the tremors, and pulse rate is about 125 per minute. The pulse rate is 125 per minute, and he is oriented to time, place, and person. How we will ask a patient, any patient who is going to come to us, we will ask whether the person is oriented to time, place, and person. The attendant also gives a history of seizure. This patient is having the history of seizure episodes a few minutes ago. What would be the best line of management in this particular patient? How you are going to manage this particular patient who is having all these symptoms? So what is the diagnosis over here? What is the diagnosis? First your diagnosis is what? This patient is an alcoholic patient, and he's coming to the emergency with the complaints of palpitations and suspiciousness. On examination, tremors are there. This patient is having tremors, right? Pulse rate is 125. He is oriented, time, place, and person, right? The attendant gives a history of a seizure episodes few minutes ago. What would be the best line of management? What is the diagnosis first? This patient did not had the alcohol, and that is the reason, and you are having the symptoms of alcohol withdrawal. Withdrawal is the symptom. So this is a symptom of alcohol withdrawal, and you will be having the drug of choice. What is going to be the drug of choice is going to be, in this particular case, the drug of choice is going to be a benzodiazepine. Remember, alcohol is going to suppress your brain. Nicotine or cigarette is going to increase the activities in the brain. It is going to increase the acetylcholine. It is going to increase the parasympathetic nervous system, right? So here the drug of choice will be benzodiazepines, and all of them, what is going to be benzodiazepines? You can have rectal benzodiazepine, but benzodiazepine is going to be uncomfortable. Even if you have the tablet, that is going to be fine, but this chlordiazepoxide is going to be a selective one. This is a selective one, right? So this is going to be the drug of choice, chlordiazepoxide. In fact, those people who want to quit smoking, quit alcohol, we are going to give these patients, we are going to shift on the chlordiazepoxide, right? But if the patient is having liver failure, we can also give this patient lorazepam. Lorazepam is a drug which is going to be safe in liver failure. If liver is not working, then also this drug is going to be safe. This is going to be a benzodiazepine. What about this acamprosate? Acamprosate is a drug which is an anti-craving agent. This is an anti-craving agent. It is going to decrease the cravings of the alcohol, right? And what about this naloxone? So naloxone we have seen somewhere in the opioid poisoning. So this is a drug of choice where you will be having opioid poisoning. First line drug, any patient who is coming to you with opioid poisoning, you will be giving naloxone, and then you will shift this patient onto an oral drug. This is going to be injection. You will shift this patient to naltrexone. That is the oral drug we are going to use, right? So what are going to be the symptoms? So we have discussed the treatment part, but what are going to be the symptoms and what is going to be the timeline in this particular case? They are asking question based on this, right? So alcohol withdrawal timeline is very, very important. Okay, so what is going to happen in the first 6 hours? You will be having what? Tremors. If you are not going to drink alcohol for the first 6 hours, in an alcoholic patient, you are going to have the tremors. For 12 to 24 hours, you can have the hallucination. Okay, you can have the hallucination. The seizures you can have within 24 to 48 hours. You can have seizures. You can have seizures in the body, abnormal contraction of complete body. Tremors will convert into seizures. Why we call it seizure? Remember, seizure is something which is having a cause. Whenever you are having a cause is causing some kind of abnormal movements in the body, this is known as seizure, right? If you do not have cause, we can call it epilepsy as well, right? So seizure is going to have a cause, like febrile seizure means because of fever. Febrile means because of fever the patient is having seizure, right? Then we can have this delirium. Within 48 to 72 hours we can have delirium, right? Within 48 to 72 hours we can have the delirium, right? And this patient will be having psychotic symptoms after 72 hours also, right? You can have symptoms like illusions can be there. You can have racing heartbeat. You can have high BP, continued perspiration. You will be having high fever, and ultimately, what happens? This patient is going to die. If you are not going to give alcohol to this particular patient, he will be dying. So I've seen a case where someone is trying to quit the alcohol, and he has locked himself inside a room, and ultimately, what happens? After 3 days you will be dying, right? This patient has died because of this particular symptoms. He'll be having tremors, hallucinations, seizures can be there, delirium can also happen, and this is going to lead to death of the patient. So for the treatment, we are going to give what? We are going to give benzodiazepines to the patient. We are going to give certain drugs like acamprosate, which is going to be anti-craving agent. You are going to decrease the craving. You are going to give benzodiazepines to the patient, so that this patient will be having normalization of the symptoms, right? Now, next question we are having is a 23-year-old male patient who is who was on the treatment of depression, and he has consumed a large amount of tricyclic antidepressant pill, right? He was on the treatment of depression. During the depressive episodes, and brought to the emergency room with the hypotension. Patient is having what? Hypotension. Remember, this TCA are going to be cardiotoxic, they can cause hypotension. This patient is brought in the altered sensorium. Patient is having a altered sensorium, and EEG is going to show you wide QRS complex, and this wide QRS complex is very suggestive of this tricyclic antidepressant toxicity. This is going to be very suggestive of TCA toxicity, and here you will be having, in TCA toxicity, you will be having metabolic acidosis, and this acidosis will be treated best with what? It is treated best with the soda bicarb. So answer in this particular case is going to be what? Sodium bicarbonate. Sodium bicarbonate is the drug of choice for TCA toxicity. This is the simple statement that we are having, right? Normally SSRI you are going to give to which patient, and SNRI you are going to give to which patient. You are generally avoiding this TCA pill. They can be cardiotoxic, they can cause toxicity. So you are generally giving in mild to moderate depression, you can give SSRI to the patient. In severe depression you are going to give SNRI. This is going to be serotonin norepinephrine reuptake inhibitor, whereas SSRI is going to be selective serotonin reuptake inhibitor. Okay, next question we are having is about the Priya, right? Priya is a 24-year-old female. She wants to be the center of attention. She wants to become the center of attention and exaggerates everything. She's exaggerating everything. She's going to tell everything very large, right? And making it sound very important. Whatever she says is very important. Then really it is, right? And she behaves in a very extrovert manner. She's behaving in an extrovert manner, and because she uses and sometimes she uses what? Physical appearance to draw the attention of the people. That is what is happening nowadays. And she can be best suited in which of the following category? So is it a histrionic PD? Is it a borderline personality disorder? Is it a narcissistic PD? Okay, is it a mania? Okay, so this is a patient who is going to be happy with self. This is a patient with happy with self, right? And this personality disorders, I have already told you, these are going to be egosyntonic. Egosyntonic means whatever personality you are going to have, you will be happy with yourself. Yes, this answer in this particular case is going to be what? This is a histrionic PD. This is a histrionic personality disorder. Narcissistic, what are the different personality disorder we are having? We are having three types of clusters of personality disorder. These are going to be what? First is going to be paranoid personality disorder. Cluster A will be having paranoid personality disorder. Then we have schizoid personality disorder. Then we have schizotypal personality disorder. Cluster B is going to have antisocial personality disorder, histrionic personality. We are having narcissistic and emotionally unstable personality disorder. Cluster C is going to have avoidant personality disorder, OCD, obsessive compulsive personality disorder, and dependent personality disorders, right? So let's try to learn about all of them, small points about them. What are this cluster A, what are this cluster B, and what is this cluster C? So this is going to be your cluster A personality disorder, where you will be having the first personality. This is going to be paranoid. Paranoid personality are going to be, these people are going to be suspicious. They are always having suspicion, suspicious. They are going to be suspicious people. If you ask the OTP, they will be like, they will be thinking like that you are going to take everything from their account, even if you are their friend, right? So they will be having suspicious. They don't trust anybody. They don't trust anyone. If you ask for phone, they will not give you, right? These are the people, they are going to be paranoid. Okay, second we are going to have is going to be schizotypal or schizoid. Second one is going to be schizoid, right? The schizoid people are going to be socially detached. They are going to be socially detached. They don't want to go out. They don't want to go out. Okay, they are going to be very less emotionally expressive. They don't want to talk with anyone. They are very less expressive. They don't want to have this expression thing, right? They are socially detached people. They are going to be less expressive. Whereas schizotypal is going to be what? Schizotypal are the people, they are having social discomfort. They are also having social discomfort. They don't feel good with lots of people, right? They can have cognitive, they can have cognitive distortion. So these are the three types of personality disorder we are having in the cluster A. We are having paranoid, we are having schizoid, we are having schizotypal. Second, in the cluster B, we are having first personality. This is going to be antisocial. Antisocial are going to be those people who have no mercy. They don't care about other people. They will violate the rights of other people. They will kill other people. They will beat other people. They don't have heart, right? They are heartless people. No mercy. Second one we are having is the borderline people. Borderline personality disorder. Borderline PD. These are the people, they are going to be very, very impulsive. They are going to be very, very impulsive. When they come into relationship, they will be like, okay, this is the best thing that we are having, right? And they will be like very impulsive, and they will be having unstable relationship also. Unstable relations also. Next one is going to be histrionic PD. Histrionic. Just now we have discussed, these are the people who are going to exaggerate everything. They are the people who are going to have excessive attention seeking behavior. They are the people who are having excessive attention seeking behavior. They want to be the center of attraction every time. Then comes the narcissistic people. Narcissistic people are going to be the people who are having self-belief, and which is going to be a firm and fixed belief that they are superior. So they are having, you can call them the delusion of grandiosity will be there. They do not have empathy. They do not understand the feelings of other. They will be like they are everything. That is the narcissistic type of personality disorder. Now in cluster C, we are going to have what cluster C will be having. First one is going to be avoidant type of personality disorder. And these avoidant people, they are going to be very, very hypersensitive to the rejections, right? If someone will say something, they will be very, very hurt. They will get very hurt, right? Hypersensitive to rejection. Hypersensitive. They do not get they do not accept the constructive feedbacks. They'll be like, they will always want the positive things. If you give the negative feedbacks, this is going to be a very bad thing for them. So hypersensitive to negative feedback or negative evaluation. Then comes the dependent personality disorder, where this person is going to be dependent on another person for the every approval, right? So they are going to be submissive type of person, and they are going to be dependent on others. Okay, and lastly we are having is obsessive compulsive disorder. Compulsive type of personality disorder. These are the people who always seek perfection. They want everything to be perfect. They always seeks perfection, and they always want to be in control, right? So these are going to be the personality disorder. Remember, these personality disorders are going to be egocentric. That means they are loved by the person. If a person is a narcissistic person, he will be happy with himself. If a person is a dependent person, he will be happy with himself, right? So these are going to be egocentric, right? All of the following are features of pseudo hallucination. What are the features of pseudo hallucination? What is a pseudo hallucination? First of all, you need to understand what is hallucination. You already know what is hallucination. Hallucination is the false perception of a real object. False perception of a real object. False perception of a real object in the outer and objective space. In outer and objective space, this is going to be what? This is going to be this is going to be hallucination. And it should occur without stimulus. Yes, it is a true statement. That means it should occur without stimulus. It's not under your willful control. So they are not under willful control. Yes, it is also true statement. Like we cannot call someone, like you have seen movie Gandhiji, right? Not Gandhiji, that is Munna Bhai, right? So what is going to happen? They can call Mahatma Gandhi, right? So he can see clearly, he can see everything clearly. So they are going to be very, very vivid. They are going to be vivid, and they are perceived in objective space. This is also a true statement by mistake. So they are not perceived in subjective state. They should be perceived in subjective state. If it is written like that, then this will become the answer. This will become the answer. This is going to be the pseudo hallucination. Pseudo hallucination means like if I talk about voices, if I talk about which hallucination, I'm talking about auditory hallucination. If I'm talking about auditory hallucination and voices are coming from outside, that means this is going to be what? This is going to be a hallucination. This is going to be a hallucination. If voices are coming, but these voices are coming from inside, I can hear something, someone is talking to me, and these voices are coming from inside, this is going to be what? This is going to be pseudo hallucination. This is going to be your pseudo hallucination. Whereas if voices are coming from outer objective space, if it is coming from outer objective space, this is going to be hallucination. If it is coming from inside or inner subjective space, this is going to be pseudo hallucination. So this is a feature of pseudo hallucination. Rest are the features of hallucination, right? So this is going to be the difference. If it is happening, if I can see someone very clearly near me, this is going to be what? Hallucination. If I close my eyes and I can see someone very clearly, this is known as pseudo hallucination, because now I can see in the inner space, in the inside, right? It's not outside, not in the objective space, not in the outside space. This is going to be the thing, right? Now the next question we are having is, a 25-year-old male patient is having some sort of a disorder characterized by, after killing his victim, he licks the wound and he drinks the blood and he eats the flesh to gain the sexual pleasure, right? And which of the following is best explaining this particular thing? What is this? This is a necrophilia, necrophagia. Is it a fetishism or a clismaphilia? So let's try to understand what is necrophilia. Necrophilia is going to be sex with the dead body. When someone is doing the sex with the dead body, this is going to be necrophilia. What is clismaphilia? When someone is using enema for sexual gratification. When someone is using enema for sexual gratification, this is going to be what? If someone is using enema for sexual gratification, this is going to be known as clismaphilia. What is this fetishism? Fetishism means you are going to use inanimate objects, and you are using objects of any female, inanimate objects, to achieve the sexual pleasure. Inanimate object for sexual gratification. This is going to be what? This is going to be fetishism, gratification. And necrophagia means you are eating the dead body, eating the dead body or dead person for same gratification. This is going to be what? This is going to be the thing. So here, which one is best explaining this? This person is drinking the blood, is licking the wound, he is eating the flesh. This is definitely going to be in the favor of necrophagia as compared to the necrophilia. Necrophilia is something else. So we are having this particular disorders, multiple group of disorder. This is a table from the book, right? So we can have sexual dysfunction disorders, like we can have what? We can have hypoactive sexual disorder. We can have sexual aversion disorder. Female can have arousal disorder. Male can have erectile disorder. Okay, just go through them once. Okay, females can have orgasmic disorder. She is not going to have orgasm. Males can have premature ejaculation. Males can have orgasmic disorder also. There can be dyspareunia, that is going to be the pain during intercourse. Patient can have vaginismus also. So these are going to be the psychogenic causes. All of them are psychogenic. What are organic causes? Organic diseases can be substance abuse, okay, sexual dysfunction due to certain medical conditions like diabetes, sexual dysfunction due to combined factors. This can be psychogenic as well as organic, right? This is going to be the dysfunctions, right? Second, we are having a lack of emotional satisfaction from behavior. This is going to be disorder which are not otherwise specified. We can have sexual identity disorders, we can have sexual dysfunctions also, right? But the important one is going to be difficulties. These you have to remember. One is going to be gender identity disorder. This is going to be gender identity disorder that can happen nowadays. We are having people who are changing their sexual orientation, right? This is the people who are having what? Gender identity disorder. That means they will say that I am a female from inside, but outside my organs are looking like a male, or the vice versa. Same thing can also be said in the cases of males also. Next thing is about the homosexuality. This is not going to be a psychiatric disorder, right? Next thing, we are having certain paraphilias. Paraphilias are sexual aversions or sexual crimes. We can have this pedophilia when you will be having involvement of a child. When you will be having involvement of a child, this is considered to be as pedophilia. The child is known as catamite, and you can have this you can have gerontophilia also, you can have pedophilia also. Okay, voyeurism is what? Voyeurism is to see someone doing maybe changing the clothes, maybe they are doing some intercourse activity, and if you are looking at that, that is going to be voyeurism, and it is going to be a sexual offense. It is going to be a criminal offense. You will be having punishment for 7 years, right? Exhibitionism is going to be to show someone your private organs. This is going to be what? In a public area, this is going to be doing the exhibition, right? Rape is going to be the thing we can have, right? Apart from the rape, we can have what? Frotteurism. Frotteurism is what? Rubbing the genital, rubbing the in public area, rubbing genital against someone. This is going to be what? This is going to be the frotteurism. Okay. There are going to be certain other paraphilias which are not sexual crimes. This is going to be what? Masochism. Masochism is going to be what? Masochism and sadism is a like when we have masochism and sadism together, this is going to be known as a combination. This combination is known as bondage. One person who is going to give pain, another person is going to suffer from the pain. So this masochism is the person who is going to suffer from the pain. He is going to love suffering, right? So this is going to be the masochism person, whereas the person who is going to give the pain is going to be what? This is going to be a sadistic person, sadism, right? Transvestism is what? That is wearing the clothes of the opposite gender. That is going to be your transvestism. What is this fetishism? We have already seen fetishism and frotteurism, right? Fetishism is using some inanimate objects. Okay, the inner wears of a female or maybe a male person, that is going to be what? Fetishism. You are going to use inanimate object. Okay, so these are going to be the gender problems. These are going to be the dysphorias that we can have and paraphilias that we can have, right? So this is going to be the necrophagia. Right. The next question we are having is a 23-year-old male patient is presented to OPD with the excessive sleeping in daytime. Someone is sleeping in the daytime, excessive sleeping in the daytime. He falls asleep when he was driving for work for long distance, and during laughing also. And he's also had sometimes hearing of voices while going to the sleep. And this is going to be the most likely diagnosis in this particular case. What is going to be your diagnosis? The diagnosis is here is going to be narcolepsy. This patient is having what? Narcolepsy. Narcolepsy patient will be sleeping anywhere. This is a narcolepsy patient. Here you will be having attacks of sleep. You can have sleep attacks. This patient is driving a bike and suddenly he will sleep because of decrease in the latency of REM sleep. This thing is happening because decrease in latency of REM sleep. REM sleep. What is going to be the drug of choice in this particular case? The drug of choice you are going to use is modafinil. Modafinil is the drug of choice that you are going to use. Okay, you can have two types of hallucination. Here you will be having hypnogogic hallucination. Here you can have hypnopompic hallucination. Hypnopompic and hypnagogic hallucination can happen. Hypnagogic means while going to sleep. If you are having some kind of hallucination, gogic means while going to sleep. If you have the hallucination while going to sleep, this is going to be hypnagogic hallucination. If these hallucinations you are having while waking up, after waking up, this is going to be what? This is going to be hypnopompic hallucination. Pompic means when the time of at the time of waking up. What is this somnolence? Somnolence means excessive sleeping. Some people are having excessive sleeping. They are sleeping like 12, 13, 15 hours. This is going to be somnolence. Insomnia means decrease in the sleeping, and depression cannot be the answer. So answer in this particular case is going to be narcolepsy. Okay. The next question we are having, a 30-year-old female patient is presented to you with the symptoms of mania. She is having mania or hypomania and depression in the last 1 year. Two symptoms are already given, and with a completely recovery in between the episodes, which of the following can be used to treat this condition of the patient? So this is going to be the drug we are going to use. The diagnosis first you need to make, and the diagnosis here we are having mania, we are having hypomania and depression all together. This is going to be a bipolar patient. Mania plus hypomania is going to be what? Mania plus hypomania or plus depression. You can have mania plus depression. You can also have hypomania with depression. This is going to be what? This is going to be a bipolar patient. If the patient olanzapine we can give if that is a case of acute mania. If that is a case of acute mania, I would like to use antipsychotic first. I would like to use antipsychotic. I will be giving this patient benzodiazepines for the better sleep, right? But the ultimate thing we will be giving is going to be the lithium. Lithium is going to be the drug of choice for bipolar disorder. Bipolar disorder, drug of choice. Two poles are there. Depression is also there, and the mania is also there. So in both the poles are there, we are going to give what? Lithium. The doses you have to remember, like you will be maintaining a level of 0.8 to 1.2 milliequivalent per liter of blood, right? And you give with this loading dose. This is going to be the loading dose, but you have to maintain the level, and remember it should not go beyond this, because this is going to be a drug which is having a narrow therapeutic range. Narrow therapeutic range means you cannot exceed, you cannot decrease the dose also. You will have to keep it somewhere in between, right? Like paracetamol has a very high therapeutic index. You can give 4 drugs, 4 tablets, 5 tablets, 6 tablets. Generally it is not going to cause any harm. But this drug, if you give it like that, this is having a very narrow therapeutic index, right? So you will be having this. So you have to maintain the levels of somewhere around 0.5 to 0.8 milliequivalent per liter, right? This is what you need to maintain. Why you are not giving this is a olanzapine as a second generation antipsychotic drug. This is a haloperidol is also a first generation antipsychotic drug, which is a typical antipsychotic. This is atypical antipsychotic. And amitriptyline we have seen, this is used for the depression cases, right? So lithium has both the properties. It is also going to decrease the risk of suicide. But what are the things you can have? It can cause leukocyte, like it will cause leukocytosis. First thing, it can cause leukocytosis. The side effect you can remember from the lithium itself. Okay, it can increase the urination in the patient. It can cause thirsty. It can cause thirsty means it can cause dyspnea. Increase in the dyspnea, increase in the thirst of the patient, right? Patient can have tremors. It can cause hair thinning. It can cause hypothyroidism. Hypothyroidism is a feature, right? It can have interactions with drugs like NSAIDs. It can have interactions with ACE inhibitor or ARB or any drug that is working on kidney, that is going to be diuretic. So this can have certain relations with these drugs. Interactions can happen. It can cause nausea, vomiting and diarrhea in the patient. Muscle weakness can be there, and skin effects can be there. It can lead to acne and psoriasis. In fact, this is a teratogenic drug. Lithium is a teratogenic drug. So we are going to avoid this drug in the pregnancy. In pregnancy, we are going to give simple antipsychotic to the patients. Antipsychotic would be safer as compared to this lithium, right? We can also give other drugs for the depression, but this is how we are going to treat the patient of patient of this pregnancy, right? So these are the side effect of lithium. You can remember from the lithium itself. Okay, lithium itself you can remember. These are the side effect. What is the next thing we are having? A 24-year-old male patient is sleeping in which sleep? In the NREM sleep. NREM sleep. Which of the following can be a feature of NREM sleep? When do you see the dreams? Do you see the dreams in a nightmare? When do you see the dreams? Okay, dreams you will be finding in which sleep? You will be finding dreams in which sleep? You will be having dreams in which sleep? In the REM sleep or NREM sleep? So we are having two types of sleeps. We are having REM. REM is what? Rapid eye movement, and an REM is non-rapid eye movement. And REM you can remember, you will always remember the dreams that you see in the REM. Dreams are the royal gateways to your subconscious mind, right? Whatever your brain will be having approximately 80,000 to 1 lakh thoughts in a day. If you have all those thoughts in your brain will be having problem. Your So what your brain will do, your brain will show you the movies, right? Your brain cannot differentiate between what is true, what is false. You watch a movie, you will get connected. You have seen some aunties, right? They are watching a serial and they are very much attached to the serial. They are crying because the actor is died, or maybe the actress has died, right? They are crying, but what it is just a real, it is just a show that we are looking at, right? So our brain cannot differentiate what is true and what is false. So what your body or what your brain is doing, your brain is having lots of impulses, lots of thoughts in a day, and those your brain is going to convert them into dreams, right? You are having certain thoughts which are not completable, right? So your brain will show you those things in your dreams, right? It will be having projecting something like your let's say your brother is beating you every day, every time he saw you, and he was like, you have NEET PG examination, you have this FMG examination, or INI set examination, why don't you study, right? Your father is looking at you every time, they will be doing the same thing. So what your brain will do, you cannot do anything to your brother in the real life, but your brain can do anything, right? So you have this impulse is going to irritate your brain. This impulse is irritating your brain that even if I am studying, my brother is scolding me. I was studying since morning. So what your brain will do in the night, if you think more about it, your brain will make it as a dream, and in the dream you will be throwing stones on a dog. You are going to throw stones on a dog, or you are going to beat someone else, right? And what your brain is doing, your brain is transferring the impulses. Your brain is converting the dog. For your brain is who is the dog? That is your, maybe your brother, who is the person who is scolding you, who is bothering you, right? So that person will convert into dog, right? And your brain will be having suppression of symptoms after seeing that dream. You will be having suppression of symptoms, right? This is how our brain is working, right? So those things you can see in the REM sleep. These are going to be the things which you can remember. And here you will be having the nightmares, right? You always say, sir, this is the worst nightmare of my life. Whereas those things which you are going to see in an REM sleep, they are going to be not remembered. You are having 80,000 thoughts in a day. There are going to be things which are not even good enough for you to remember, right? And those things are going to be, can be nasty thoughts you are having. So those things are going to be coming into your mind in non-rememberable sleep, and whatever dreams you saw in that sleep, they are known as night terrors. So sometimes you can appreciate, you are sleeping in the night and suddenly you wake up. You'll be like, I had a very bad dream. And when you look for the content of the dream, you are not able to remember what you have saw, right? So you are not able to remember. This is known as night terror. You are able to remember. This is known as nightmare. So dreams you are going to see in both the sleeps, right? Now what are the contents of REM sleep and what are the contents of an REM sleep? Let's try to recap. REM sleep disorder are going to be two, you have to remember. One is going to be narcolepsy, another one is going to be nightmare. Nightmare you can remember, narcolepsy also patient can remember, right? And REM sleep, you are not going to remember anything. You are walking in the sleep, you are going to somewhere else, right? You are going to your neighbor's house. This is going to be what? Is it going to be punishable offense? Yes or no? Sleepwalking, if you go to bedroom, that is going to be punishable. But if you are walking on the streets, you can, maybe this is not a punishable offense, because it is a content of an REM. That means you don't know where you are. and REM is something you don't remember, right? So sleepwalking, also known as somnambulism. This is also known as somnambulism. Sleep talking, some people are talking in the night. They are like, I'll see that person tomorrow. He's taking long classes, right? So this is something, sleep talking. You will be looking at this particular thing. This is also known as somnaliquid, right? Those people who are living in hostel, their roommates, they are talking like that. Bruxism means grinding of the teeth, clenching. Some people are clenching their teeth or grinding their teeth in the night time. This is known as bruxism. Nocturnal enuresis is what? Nocturnal enuresis means people are going to do urination in the night time. Okay, and night terrors, that I've told you, this is something which you are not going to remember. What is the content you are not going to remember? This is going to be the night terror. Night terror, right? So all these are the disorders of sleep. Now you tell me which is going to be the disorder of an REM sleep. Which of the following can be a feature of an REM sleep? An REM sleep feature is going to be what? Sleep paralysis. Sleep paralysis can happen where? Which is going to be the feature of an REM sleep? Sleep paralysis you will be having in the REM sleep. The feature you will be having in the an REM sleep is going to be what? Teeth grinding, also known as what? Bruxism. Also known as bruxism. This is going to be the C, bruxism, right? Teeth grinding or bruxism. What is this sleep paralysis? Sometimes you are sleeping and you will feel like that someone is sitting on your chest. And you are trying to wake up, you are trying to stand up, but you cannot move your body. Why? Your body is in the REM sleep. You cannot move your body. You can move your eyes and you think like that, okay, but there is a ghost on you and he's not letting you wake up. You will tell all the you will remember all the gods, you will speak everything, but you are not able to stand up because your body is in the suspended form, right? This is what is known as sleep paralysis. You cannot move your body and you think like that you have someone sitting on your chest, and people are complaining like that, okay, I had a ghost and that ghost was sitting on my chest and he won't let me wake up. I remember all the gods and all, nothing is working. So this is nothing, this is just a sleep paralysis that you are having, right? So answer in this case is going to be teeth grinding, which is a case of bruxism. Because sleep paralysis, you remember everything. Nightmares, this is the worst nightmare, you remember everything. Narcolepsy, you remember everything. All of them are disorder of REM sleep. What is the exception? This is going to be teeth grinding. This is going to be exception, and this is going to be the answer here, right? The next question we are having is, what is the term used to describe the phenomena where a patient in the respond where a patient in the respond to the question how are you by repeating the same sentence? Now the patient is responding by repeating the same sentence. This patient is telling the same sentence again. Now what can be this possibility? Is it a echolalia? Is it a echopraxia? Just remember, lalia means what? Lalia means to speak. Lalia means to speak, and praxia means is to show some movement. Praxia is going to be to show some kind of movement. So we can have copro. Copro means bad. Copro means bad. So when you have coprolalia, lalia means what? To speak. So when you have inappropriate, when you spoke inappropriate sentences are spoken, some people are having this kind of language, they are always speaking bad. This is a coprolalia. Okay, echopraxia means repetition of a behavior. Repetition of a behavior. Like I'm going to I'm having a patient in front of me, and if I will do like that, what will happen? This patient will keeps on doing like that. This is known as echopraxia. Copropraxia means here you will be having using of inappropriate gesture. Here you will be having formation of inappropriate gestures will be there, or maybe some kind of a movement, bad movement. Copro means bad. And what is this echolalia? Echolalia means repetition of the same sentence. Repetition of same sentence. Same sentence or same words can be there. This is going to be echolalia, right? So echo is going to be what? Echo is to repeat. Okay. Copro means bad. Echo means to repeat. And copro means bad. Coprolalia means bad words. Copropraxia means bad movement, improper gestures, improper movements. Okay, that is not good, right? So in this particular case, they are repeating the same segment. What is going to be your answer? This is going to be right. This is going to be the D. This is going to be the D. Now the next one we are having, what is the fear of height is known as? Fear of height is what? What is this acarophobia? Let me just write all of for you. Acarophobia is fear of mites. Fear of mites. Mites means there can be small insect. Acarophobia, small insects. Algophobia is fear of pain. Algo is analgesic, you can remember. Fear of pain. Fear of pain. Agoraphobia is fear of a space, fear of places. Fear of places where escape is difficult. Fear of places where escape is difficult. Escape is difficult, like it's a big ground, very big ground. How you can go out, like a like it's a desert, like it's a snow ground, right? So fear of places where escape is difficult. This is going to be your agoraphobia. Agoraphobia. Acro means height. Acro means extremities. So fear of extremities or fear of height, you can remember. Fear of extremities or fear of height can be that. So this is going to be your acrophobia. Acrophobia, right? All are the stages of grief or loss. All are the stages of grief or loss. What is the stages of grief or loss? When someone is dying, what are the stages that the person is going to go into? This is going to be the mnemonic. The mnemonic is dabda. Dabda is the mnemonic. So D is going to be, first of all, he will deny. He will deny. Someone close will die. He will be like, no, this cannot happen. And this is not true. Second thing, A for anger. He will be having the anger. This is the same story will happen everywhere. Then he will do the bargain. B for bargain. He will do, okay, let at least we can have some 2 or 5 days with him, right? And then you will be having D for depression. Then this person is going to go into depression. If it is a close person, these are the stages of grief. Okay, stages of grief or loss, right? And A for ultimately that person is going to have the acceptance, and they will accept that it's okay, it's fine to be having this particular thing. So anytime you have the grief, you will be having same steps. This is going to be, first you will deny about this, then you will have the anger, you will have the bargain, you will do depression, you will go into acceptance. So what is not going to be the feature? Denial is going to be there, anger is going to be there, bargain is going to be there. If you remember this mnemonic, you are able to answer. But remember, ultimately not agitation, it is going to be the acceptance which is going to come in the last, right? Now comes the next question. Which drug among the options provided would assist a chronic smoker in their aim to quit the smoking? So if someone wants to quit smoking, one thing you have to remember, for quitting of the alcohol, I've told you it is going to be a long-term process, and you need to decrease the alcohol intake slowly. Right? You need to decrease it slowly. You have to augment with benzodiazepines. Benzodiazepines should be given to the patient, and benzodiazepine of choice is going to be chlordiazepoxide. But if someone wants to quit smoking, it should be abrupt. It should be abrupt. This should be abrupt, and this patient should be shifted to, we can give nicotine replacement therapies to the patient. We can do NRT. What is NRT? NRT is going to be nicotine replacement therapy, right? This nicotine is going to do what? This cigarette will be having nicotine, or any tobacco product will be having nicotine. This nicotine is going to activate your acetylcholine, and this acetylcholine is going to increase your peristalsis in the GIT. It is going to activate your parasympathetic nervous system. All the features of parasympathetic nervous system will be there. So you will be having more movements in GIT. You will be having better cleaning of the stomach, GIT, right? You will be having decrease in the heart rate. Decrease in the heart rate means decrease in the palpitation. It is going to increase acetylcholine in the brain, so you will be feeling fresh, right? So you will be having more cognition. That is why some people are smoking, right? Because it is going to make a cycle. It is going to release dopamine in the nucleus accumbens, and you will be getting addicted. It is not a good thing to have, right? It is totally a bad thing to have, right? So we are having this bupropion is the drug, and you can remember PO, you can remember in Hindi. This is going to be used for decreasing, this is going to be the use for decreasing in the smoking, or basically it is an anti-smoking drug. This is going to be an anti-smoking drug. This is going to be anti-smoking drug. It will decrease the craving. It is going to decrease the craving, and it is also going to maintains your withdrawal symptom also. So withdrawal symptoms maintains will be there, and it is going to decrease the craving. Whereas this mirtazapine is going to be antidepressant, which has nothing to do with here. Okay, option C is going to be vernicillin, and remember this is a previous year question. They have asked which receptor it is going to be working. It is going to be working on alpha 4 beta 2 receptor, alpha 4 beta 2 receptor, and this is going to be working on nicotinic cholinergic receptors, and it is going to be a drug we are using. This is going to be a new drug we are using for quitting of the smoking cessation, right? So these are going to be the two drugs. If two drugs are given, the answer in this case is going to be what? This is going to be D. This is going to be D. Answer will be D. Okay, next question. We are having a patient has stopped alcohol consumption for 3 days. 3 days he is not having the alcohol and presented with irritability, disorientation, paranoid delusions are there, agitation is there, visual hallucinations are there. Okay, and altered sensorium is also there. This is going to be, what is the diagnosis in this particular case? This is a case where this patient is having 3 days. 3 days means approximately 72 hours, and 72 hours you will be having symptoms. These are going to be what symptoms? Delirium tremens, I have told you, right? We have discussed in that diagram. You will identify these symptoms will be there. Paranoid delusions, agitation, visual hallucinations can be there, right? You can have this Wernicke's encephalopathy. This Wernicke's encephalopathy is going to be acute neurological disorder. This is a acute neurological disorder. This is going to be acute neurological disorder, where you will be having symptoms like Wernicke's will be having symptoms like you will be having Goa. You will be having symptoms like you can have nystagmus, you can have ataxia, you can have global confusion. The symptoms can be there, global confusion can be there, and these things are happening because of decrease in vitamin B1, also known as thiamine. So when this acute neurological disorder is going to happen, this is going to be Wernicke's encephalopathy. When this disease is going to convert and you are not going to treat this particular disease, it is going to convert into a special type of psychosis, which is known as Wernicke-Korsakoff psychosis or Korsakoff psychosis, where you will be having confusion, and very important thing, that is going to be confabulation. Confabulation is what? Making false stories. This patient himself does not know. He is going to make false stories. He will forget. This patient is going for drinking alcohol, and after some times like 8 p.m. he will start to drink alcohol, and he will come home 2 a.m. Let's say he is coming home 2 a.m. when the family is going to ask, he don't remember what happens after 8. After 8 by 9 he will be, after 8 by 9 he will be already set, right? And now what happens after 9 till 2 he's not going to remember. So he's going to make certain false stories, and he himself is also going to believe them. He is going to make stories, and he himself is also going to believe them, and these stories are not going to be not true. These stories are going to be self-made stories, right? And he himself does not know that this is a self-made story. This particular thing is known as confabulation. This confabulation will be there. The treatment you already know. This is what you are going to give, chlorodiazepam epoxide in this particular patient. You can give benzodiazepine, you can also give lorazepam to this particular patient, right? So this is going to be the treatment, this is going to be the thing. Declumbered we have already discussed, which is a fantasy lover syndrome, right? Which of the following drug abusers can lead to the symptoms described by a 25-year-old male patient who complains of a sensation resembling insect crawling beneath his skin? Very, very characteristic. This is going to be what? This is going to be cocaine bug. This is going to be cocaine bug, and this particular phenomena is known as formication. This particular phenomena is known as formication, also known as Magnan's phenomena. Magnan's phenomena. You will be having these symptoms, right? So cocaine, what are the important points if you want to remember about cocaine? Cocaine can be used as a local anesthetic also. It is going to always increase your BP, and increase in BP will lead to what? Hypertension. It will lead to hypertension. It can cause those people who are sniffing the cocaine, this is going to happen what? They are going to have nasal septal perforation. They are going to have nasal septal perforation. This is also going to cause what? This is also going to cause jet black color pigmentation of the tongue. Jet black color pigmentation of the tongue. Cannabis, you already know what is cannabis. That is going to be ganja, right? That is going to be ganja, right? And this amphetamine, we are having this amphetamine. This is also we are using as a drug, right? And cocaine you already know, and we've discussed about the alcohol. This is going to be the answer, right? In which of the following condition is labile indifference is noticed? Labile difference, here what is going to happen? You will be having certain disorders like conversion disorders. Here there will be absence of psychological symptoms. Here you will be having absence of psychological distress or psychological symptoms, in spite psychological distress, in spite having a major serious stressor over there, in spite having a major serious disease over there, like if someone is diagnosed with the cancer, right? Someone is diagnosed with the cancer, and this patient is going to be you are going to tell the patient, okay, you have the cancer, and now this patient is going to show you labile indifference. That means he will be like, okay, it's fine, it's completely fine if I have cancer, right? So this patient is not going to show you any psychological symptoms, like he's not going to show you pain, he's not going to show you sorrow, he's not going to show you the anger or something like that, right? He will be emotionally numb, and this is known as labile indifference, that is generally found in the conversion disorders. Now the question we are having, what non-pharmacological measures you are going to be recommending in a middle-aged patient who experiences PME, that is going to be premature ejaculation during the intercourse? So what you will be giving to this particular patient? Remember the CBT we have discussed. The CBT we are going to give you to anxiety patient. We are going to give cognitive behavioral therapy, not to every patient, but to anxiety or depression patient. We want to improve the cognition of the person. This exposure and response prevention therapy, I've told you, if the patient is having what? OCD. If the patient is having OCD, what is the sensate focus therapy? And what is this squeeze technique? What is the sensate and what is the squeeze technique? Let's try to understand the sensate focus therapy. This is going to be a form of sexual therapy. This is going to be a form of sexual therapy, where we are going to do certain exercises to improve what? We are going to do certain exercises to improve the communication, between the partner. And this is what we are doing, communication between the partners. And this is what we are doing to avoid the psychogenic causes between the partner, to avoid psychogenic causes, like to avoid like performance anxiety. Some people are having this particular thing, so we are calling the couple, we are doing this particular therapy. This is known as sensate focus therapy. And this technique, this is the squeeze technique that we are going to use, where you are going to squeeze just before ejaculation. So this is how you can run longer, and this is what we can do in the middle aged person. This is going to be the squeeze technique we are going to follow, right? What is the term used to describe the therapist feeling towards the patient? What a therapist is going to feel towards the patient is known as what? Counter transference, transference, empathy, or projection. That can be both conscious or unconscious, and can be both negative and positive. Some patients are going to be feelings is going to be there. It's not like a good feeling, bad feeling, positive, negative, conscious, unconscious. Feeling is feeling, right? So what is going to be the therapist feeling towards the patient? What do we call it? When the transference is what? Transference is feeling of patient towards the doctor. This is going to be the feeling of patient towards the doctor, toward patient towards the doctor. This is known as transference. What is counter transference? This is going to be the feeling of, counter means opposite, what a doctor is giving, right? This is going to be a feeling of therapist towards the patient. This is a feeling of therapist towards the patient. This is a feeling of therapist towards the patient. What is empathy? Empathy, what is empathy? Empathy is the ability of a doctor. It is the ability of a doctor to understand and share the feeling of a patient, to understand and share the feelings of a patient. This is known as empathy. That means you are having sympathy, you are having empathy, basically, right? You are having projection. Projection means you are projecting something on someone else. Like you are having we are having thoughts projection, like we are having a person who is projecting his thoughts on a second person. This is going to be the thought projection. Someone is fighting with you, like a boss has scolded you. This is the boss who has scolded you. Now what you will do? You will scold someone else, right? So this is going to be what? This is going to be the projection that we are having. So here in this case, this is going to be counter transference. Okay, last two questions we are having. Try to answer this one. Which of the following facts about structural theory of mind is going to be correct? What is the structural theory of mind, and what are the fact is going to be incorrect? They want to know about incorrect. Okay, so we are having three things. One is going to be id, another one is going to be ego, and the last one is going to be superego. So what your id will say? Your id will work on the pleasure principle. It will always say what is there in the psychiatry, let's go have some fun. This is going to be the id principle. Why to study? This is going to be the id principle. What superego will do? Superego will say always good things. He will be like, okay, you should study all the time, you should become the best doctors in the world. In the India, you should become the best doctor. This is going to be your superego, right? And you are working somewhere, that is going to be the ego. You are working somewhere, you will be like, okay, let's take this particular class of psychiatry, and then I will have a good dinner. So you are balancing somewhere in between. That is what we are having the ego. You think like that. Okay, let's finish last two questions, and then I will go for a very good dinner. This is going to be the ego which is working, right? So this is going to be the ego which is working. Now they want to know which is going to be incorrect. This is a part of structural theory of mind. We are having structural theory of mind, and this is the part we are this structural theory of mind is telling. This is going to tell us about the id, ego, and superego. Like we are having subconscious mind, we are having preconscious, and we are having conscious mind, right? So what is going to be the id? The id operates on the pleasure principle and lacks impulse control. Yes, it is a true statement. The ego is executive organ of the mind and balances the demands of the id and superego. Yes, it is also a true option. This is what we have discussed, right? And Third one, the superego develops between 5 to 6 years of age and is mostly present in the conscious part of the mind. We don't know about it, right? The structural theory of mind consists of id, ego, and superego representing different aspects of mind. Yes, it is also true, right? So which is going to be the false statement? The false statement is going to be this one, because the superego is going to develop a little bit earlier. So this is going to be a false statement, and they are asking for what? They are asking for an incorrect statement. This is going to be the C is going to be the answer in this case, right? Now comes the last question. Which of the following statement about the image given below is correct? Okay, which of the following statement about the given image below is correct? This type of ink blot charts that we are having, these are known as Rorschach test. These are known as Rorschach test. What is the name of this test? The name of this test is going to be Rorschach, and what they want to know? They want to know about the incorrect statement. Okay, the image is one of the cards used in the Rorschach test. Yes, it is true. The description of the image is objective. No, it is not objective. The image are typically symmetrical and ambiguous. Yes, it is also true. They are looking symmetrical and ambiguous. The test involves asking individuals to interpret what they see in the images. Yes, this is also true. So what is this Rorschach test? If we are having patients of like a patient is coming with the symptoms of schizo, we are going to give this test to the patient. We are going to show certain images. These images are going to be Rorschach images. Now some people can see it as a butterfly, some people can see it as a monster, right? So this is what is going to be what is it going to be objective? That means it is going to be true for everyone should see the butterfly, or everyone should see the monster here. No, it is going to be a subjective finding. This is going to be a subjective finding. That is why we are giving this, right? Every individual will see different things based on his own imagination, based on what is running in his mind, and that is what we want to know with the help of these charts. If a patient is seeing a butterfly, that means he's looking at positive things, right? If he sees some kind of a monster over here, this is going to be something. This is how we are going to interpret this particular Rorschach. Your psychologist will do the understanding of these things, and they will be making a report, and ultimately we will be getting that report, right? So this is going to be the thing, right? So with this thing, we are done with the psychiatry. I have tried to incorporated most of the important questions that has been asked in your previous examination. Along with that, I've just tried to cover a lot of theory, right? And the quote for the last, and the quote is that a river cuts through a rock not because of its power but because of its persistence. So you are having not just too many days for the examination. Keep working hard persistently, and you will definitely ace your examination. My best wishes are always with you. If you have any difficulties, you can always connect with me. You can always ask about the doubts. I will be more than happy to help you out, right? So thank you so much for all the patience, and keep learning. Did you find the psychiatry easy? Did you understand what we have discussed? I will share this PDF, and you can get the PDF as well. In the group, you can also get this PDF. I'll share this, right? So with this thing, I'll take a bye. I'll take a bid. Thank you so much. Good night, guys.